Maybe as we wait, Dr. Matu, would you like to say a word or two? Welcome people officially to Kitui. Yeah.
Good morning, everybody. It's my pleasure to welcome you to Kitui County today for the conference, and thank you very much for doing a very successful surgical camp where you almost attended almost 200 patients, and all of them are well and about to be discharged from the hospital. When you're around, try to take a walk and see the nice attractive sites we have in the county. We have a magic rock which you can be able to change your gender at no cost if you want. That's the Nzabani Rock. It's about 7 to 8, 10 kilometers from here. The road is good, it's passable. There are recreational facilities, and you can enjoy a drink there and take very nice pictures when you're on the rooftop. The only advice I can give you is that don't try the joke of 7 rounds, because your partner or your wife or your hubby may have a problem to identify you after that. But you can enjoy the scenery. There's a national park just in the neighborhood where there are very nice monkeys, but there are also elephants who are rogue, so you also take care of that. Above it, there's a town called Kalundu. This town is on your way to Nairobi. It's about 1 kilometer from here. That is with the African market. Where we are is a European market. The reason why it was an African market is that Africans make noise. The Mzungu and the Asians didn't want Africans to intermingle with them during colonial time. In that town, they sell kamote in kilograms. So if you want to practice a bit of it and enjoy the feeling of kamote, then you can also go there in the evening and buy either 1/4 kg. Don't buy more than 1/4 kg. It may be too much for you. So it's available. We don't have witchcraft in Kitui. So be assured of that. There are no witches here. But we can give you kamote to make you become very rich, or to win a very nice partner, or become a politician, or if you want the president also. So there are a lot of nice things. We have very nice honey products in the market, affordable, refined. The best goat is in Kitui, and the best recreational sites and the resorts are also available. So don't confine yourself in Parkside Villa. Take a walk around and make the best out of it. There are also resident tutors for those who don't know how to speak Kamba. They should be able to be taught a bit of it. Feel free and welcome. Thank you.
Just to remind you again, please load your presentations in time so that we don't go into what we are going through now. Okay. There is a bit of problem on the system. If you have your laptops, you can actually present from your laptops directly, but still come and liaise with the system people here. Matu, I'm not very sure there is no witchcraft in Kitui. I don't know. All I know is that there is no busa in Kitui. Hotel and I were looking for busa, we didn't get any. So we start with ladies. start maybe. No? Well, this.
Sorry, we have ran into some hitch. We're trying to do both, it's a hybrid meeting, so they're trying to have both Zoom and this physical meeting. I think if you allow us, we'll ask Dr. D.K. Kimani to start us off in the analog way. Thank you, DK. Dr. Kimani.
Dr. Kimani is going to talk on prostatitis incidence, diagnosis, and management. He's going to send us through the overview and what is current. You all know Dr. Kimani. Those of you who are in Mwingi, I think, you interacted with him. Very versatile young man.
Mito. Seems like yours is up, so let's proceed.
Okay, we go back to Omito. I think they've sorted out. Please just remember the talk is for 10 minutes. If you have spoken for 7 minutes, please wind up. Try to stick to the substance of the presentation. Don't go into unnecessary detail. We'll be warning you at 7 minutes.
So, okay, thank you, Chair. Good morning, everybody. My name is Dr. Mito, and I'm going to be taking you through the current management of benign prostatic enlargement. So, as an introduction, most elderly men will suffer from LUT secondary to BPH. BPH involves hyperplasia of both the stromal and epithelial aspects of the prostate. The prevalence usually increases with age, and it's observed in histological studies that around 8% of people suffer BPH in the 4th decade. By the 6th decade, this has usually increased to 50%, and by the 9th decade, is usually above 80%. Also, traditionally, the goal of treatment in BPH has been to alleviate bothersome LUTs from the prostatic enlargement. However, it has been increasingly shown that the LUTs in BPH are usually multifactorial and may result from other factors such as detrusor disorders you can have, overactivity and underactivity, infections, and other CNS abnormalities. Also, an important aspect in treatment of BPH currently is that there is additional focus on prevention of disease progression and subsequent complications from progression. And as medical management of BPH has progressed, there is a decrease in the number of surgeries done for prostatic enlargement. On the pathophysiology of LUTS in BPH, there are usually three mechanisms. There is mechanical obstruction from growth of the prostate. Then you have dynamic obstruction for this tone of the smooth, increased tone of the smooth muscle of the prostate and bladder neck. And you can have detrusor instability due to hypertrophy. So how do you assess patients coming in with benign prostatic enlargement? The first thing is usually a complete history and physical examination, including a digital rectal exam. Then you have symptom questionnaires like the IAAF and IPSS score. You can also have basic lab tests like urinalysis, PSA, and UECs. Then there's also assessment with ultrasounds, including post-void residual and Ureflometry. After diagnosis, right now there's an approach of stratification of patients, which usually divides them into treatment-oriented subgroups. So this usually helps to guide you in terms of medication and can tailor the needs to the needs of each individual patient. So currently there are 5 groups proposed in the stratification of patients for BPH. You have patients who are at risk of progression. You have patients with nocturnal polyuria, patients with predominantly storage symptoms, patients with predominantly voiding symptoms, and patients with associated erectile dysfunction. So the first group of patients are the patients with predominantly voiding symptoms. So for these patients, monotherapy has been the mainstay, but monotherapy in these patients is restricted to patients who are at low risk of progression and patients with mild to moderate symptomatology. So alpha blocker therapy usually improves storage and voiding symptoms by even up to 40%, but don't affect disease progression. So this is a table showing currently available alpha blockers. Currently in our setup, the most commonly used agents are tamsulosin and alfuzosin, but silodosin is now currently available in the market. All the alpha blockers available have comparable efficacy, and they usually have a varying degree of side effects. For alprazosin, terazosin, and dexazosin have more of the vascular side effects, especially postural hypertension. Tamsulosin and silodosin are usually involved with a lot of retrograde ejaculation. So the second group of patients are patients at risk of progression. So these are basically patients with a prostate size of more than 30 grams, a PSA of more than 1.4, an IPSS of more than 12, and a Qmax of less than 10. So patients at risk of progression usually require 5-ARI therapy in the form of combination therapy. So the two 5-ARIs currently available are finasteride and dutasteride. Finasteride usually inhibits type 2,5-alpha reductase, while dutasteride inhibits both type 1 and 2. Both agents reduce the intraprostatic 5-alpha reductase by up to 90%, and dutasteride will inhibit more of serum dihydrotestosterone. So while on treatment for these patients, the PSA usually is reduced by up to 50%. So on the 5-ARIs, both agents have similar efficacy, and they work by reducing prostatic volume by up to 25%. There is 50% reduction in episodes of acute urine retention and surgical intervention. Then both agents will improve symptom score, they will improve urinary flow, but the maximal effect is usually after 6 months. So they have a durable effect lasting up to 10 years, and as an off-label indication, they usually reduce hematuria in BPH. So the side effects include sexual dysfunction, all aspects from libido to ejaculatory dysfunction. Then they usually also cause breast enlargement, breast pain, and nipple pain. So as I've said, for patients with risk of progression, all evidence points at combination therapy. So the hypothesis behind combination therapy is that the alpha blocker will give early symptom response, and the long-term durability of symptom response and prevention of progression will be by the 5-ARI. Then the combination is usually safe with no additional side effects from the individual drugs. So when we talk about combination therapy, 2 trials usually come the front. We have the combat trial and the MTOPS trial. The combat trial had 3 arms. There was dutasteride monotherapy, tamsulosin monotherapy, and combination therapy, while MTOPS had finasteride monotherapy, doxazosin monotherapy, combination of both the agents, and placebo. So the endpoints of these 2 trials, in the combat trial, combination therapy was significantly superior to tamsulosin monotherapy in terms of reducing risk of urine retention and BPH surgery. It was also superior to both monotherapies in reducing the risk of clinical progression of BPH. Then it also had a sustained benefit over monotherapy at 4 years, and the safety and tolerability was consistent with previous experience on both agents as monotherapy. In the MTOPS trial, the study found that combination therapy was more effective than either therapy alone in preventing the progression of BPH. So this is also a very important diagram on combination therapy. In terms of both agents will improve the symptoms of flow, but the alpha blocker will have an early onset of symptom relief. Both agents will prevent symptomatic progression in the short term. The advantage of the 5-ARI over the alpha blocker in this will be that the 5-ARI will reduce the prostate volume and will maintain the prostate volume. It will also reduce the risk of acute urinary retention and surgery. Of importance also is that the magnitude of the benefit of the alpha blocker usually decreases with time. For the 5-ARI, the magnitude of the benefit will increase over time. Then when do we initiate combination therapy? Also on this, most evidence is supporting early initiation of combination therapy. So if you delay initiation of the alpha blocker, there will be a greater symptom severity for a longer period. If you delay initiation of the 5-ARIs, there is an absolute increase in the risk of acute urine retention and BPH-related surgery. But combination will lead to rapid reduction in symptom severity and an absolute reduction in the risk of adverse outcomes. So the other group of patients are patients who have nocturnal polyuria. Nocturnal polyuria is defined as production of more than 33% of the 24-hour urine output overnight time. For patients with the nocturnal polyuria, the mainstay of treatment is desmopressin. 3 formulations are available. You have the oral tablet, you have a sublingual tablet, and a nasal spray. So in the USA, the FDA has approved the nasal spray and the sublingual tablet. Locally, you have the oral tablet 0.2 milligrams, which can be used. So desmopressin
We are at 8 minutes now.
can reduce episodes of nocturia by up to 50%. And these patients are at low risk of adverse events, but due to possible cause of hyponatremia, we should periodically monitor the electrolytes. Another group of patients are patients with predominantly storage symptoms. These patients usually benefit from 2 groups of medications. You have the anticholinergics and beta-3 agonist mirabegron. So patients on anticholinergics should be warned on possible side effects like a dry mouth and constipation, and anticholinergics should be avoided in patients with a high PVR of more than 150 mils. The last group of patients are patients with associated erectile dysfunction. So it's basically known that these conditions are highly prevalent in men with BP, with associations between them being independent of age and comorbidities. So the only agent which is approved for treatment of erectile dysfunction and LUTS is tadalafil at a dose of 5 milligrams OD. Of importance in that it will improve IPSS and the IEF score, but not Qmax. So as monotherapy, it should be used in mild symptoms. Of importance, all patients on sexual enhancing drugs will ask you about the safety and tolerability. It is safe in patients on treatment for diabetes. It is safe with patients on antihypertensives, but it is usually contraindicated in patients on treatment for angina, myocardial infarction, poorly controlled hypertension. So this flowchart basically summarizes the presentation. So all patients who are on risk of progression should be on 5-ARIs in the setting of combination therapy. Patients with predominantly voiding symptoms should be on alpha-1 antagonist. If they have a risk of progression, they should be on combination therapy. Patient with predominantly storage symptoms also again should be on an alpha antagonist. If they have a risk of progression also, they should be on combination therapy. In addition to this, they can also receive anticholinergics or mirabegron. Then patients with symptoms of ED would benefit from PDE5 inhibitors. Those were my references. Thank you.
Thank you, Dr. Omito. I think Dr. DK. We have a timer, so just listen to the timer. We'll make some noise, and then you know you're at 8 minutes. Okay. Thank you. DK.
Just before GK talks, the following cars need to be removed from where they are parked to a different site. KAV 968A, KCS 174W, KCP 655U, KBQ 951J, and KCR 498B. That's mine, but I'm not removing it. Anyway, KAV 968A, KCS 174W, KCP 655U, KBQ 951J.
Can we be guided as to where to park?
I think that sounds like everybody has to go and remove their car. I think we proceed a bit with our session. DK.
Thank you. Good morning. My name is Dr. Kimani from Kenyatta. I'll be talking about chronic prostatitis. And I come carrying bad news because it's a disease that is difficult to treat. I don't know how to treat. I'll tell you how I try to. We know the National Institute of Health classified prostatitis into 4 categories: the acute bacterial prostatitis, the chronic bacterial prostatitis, and our big old enemy, the chronic prostatitis, or the chronic pelvic pain syndrome, which constitutes a bigger fraction of these patients. And then there's a 4th group that we all know is mainly on research basis, who have asymptomatic inflammatory prostatitis. So I'll try and confine myself to a large extent on this particular group, who are the headaches for most urologists. By definition, these patients, you have chronic pelvic pain, and importantly, they must have had the symptoms for at least the last 3 months, in the preceding 6 months, 3 of the preceding 6 months. Because the disease sometimes wax and wanes. It comes on, and then they go into a remission. Number 2, and it's important that you must identify, you must look for identifiable causes, and if there are, then it ceases being chronic prostatitis. Some you have, in fact, a number of them you have urinary symptoms, and they may or may not have sexual dysfunction. And you realize the ones with sexual dysfunction are perhaps the most difficult group to treat. These patients may be classified as having either inflammatory or non-inflammatory prostatitis, but this is on account of the histology, and it's for purposes of research, not necessarily because they behave differently or their response to treatment is any different. It's a very common problem, and I'm sure most of you will attest that these are the patients. They are very common patients in your facilities. And I was looking at my data to see how or what information can I gather from that data, and it's very difficult because you start a patient on treatment. After 1 month, they have gone to Professor Mungai, who introduces a second drug. Then they will come back to you, go to somebody else. That means even if you are to gauge the response to treatment, it becomes very difficult. They will have seen a couple of other colleagues before they come to you, and you find yourself you are starting at the same treatments again, and it becomes very difficult. They constitute a significant proportion of patients. From my cards, the last 100, I saw like 10, so a little bit less than what we find in literature. The mean age for my patients was at 8 years, and the peak in the literature is at the 5th decade, that's in their 40s. So I found out that my patients are tend to be a little bit younger than what is described in literature. And most men diagnosed with prostatitis have CPPS rather than the acute or chronic bacterial prostatitis. I think that is That is self-explanatory. If you are to look at bacterial prostatitis, especially the chronic bacterial prostatitis, is one thing that you must differentiate from CPPS. And we all know the organisms that are responsible are mainly organisms that are also responsible for most of us urinary tract infections, because one of the thinking is that there is egress of urine back, or reflux of urine back to the ejaculatory duct and up to the prostatic ducts, giving the symptoms. And what you notice about these bacteria, if you have been treating and doing cultures and sensitivity for patients with UTIs, we are seeing a lot of resistance to antibiotics for these organisms. And you find, most of the times, you're finding either they are responding to carbapenems or imipenems, or they're responding to gentamicin and amikacin, those organisms. And the other one is phosphomycin and a bit of nitrofurantoin. A lot of resistance to the quinolones, which we have traditionally used to treat prostatitis. And those with bacterial prostatitis will tend to have a little bit of urinary symptoms, mainly the dysuria, and they complain about a urethral pain, some persistent pain when they are passing urine. And they may present with recurrent UTIs. Every time they come with multiple urinalysis that shows presence of bacteria. When you examine them, these are the ones who are likely to have a tender prostate and on examination, and they are very shy of you doing a DRE because it's very uncomfortable. They also tend to complain about some pain around the belt area, that they have to loosen their belts at all times because they find the belts a little bit uncomfortable. When you look at the chronic prostatitis, CPPS, and go a little bit into its pathophysiology, we know it is either inflammatory or non-inflammatory. We do not know what are the organisms, what are the trigger. Is it an infection that triggers? Is it a chemical that triggers this inflammatory process? But we know the air defects is that it will have an influence on the nerves innervating the perineum, and in so doing, create a form of voiding dysfunction and some myofascial pains that tends to aggravate the problem. A little bit of them, or a few of them, we have a psychological component, and you have extra prostatic symptomatology. These are the patients who you have back pain sometimes. You have, besides erectile dysfunction, sexual dysfunction, they may have bowel symptoms, especially symptoms attributable to irritable bowel syndrome. And perhaps these are the biggest population of patients who are very worrying for you. The theories are there in terms of the antibiotics, resistant organisms that perhaps persist, meaning there's a chronic inflammation, chemical irritation, reflux, avoiding dysfunction, where you are avoiding against a closed external sphincter, and therefore egress of urine back, leading to neuropathic pain. And some people think there is a bit of inflammation of the prostate, making it a bit bigger and causing pudendal nerve entrampment. And also some people think there might be an autoimmune etiology to it. Most patients you present with perineal pain, suprapubic pain, coccygeal, rectal, or testicular pain that is for more than 3 months, like you have said. A bit of inner symptoms, the commonest being frequency. A few of them you complain about the incomplete voiding. Some may have ejaculatory pain, and a couple of them you have erectile dysfunction. And perhaps when you examine them, the main things that you may find is pain at the prostate. Either when you examine externally, you find some tender spots between the scrotum and the anal opening. And then they have a tight anal sphincter on digital rectal examination. To be objective in the assessment of the severity, we have the International Prostatitis Score, again developed by NHS, NIH, that gives you an idea about how severe your symptoms can be, so that then you can be able to gauge this patient's response. We know chronic prostatitis or acute bacterial prostatitis can complicate in all this manner, but I wanted to underline the last part of this, that chronic prostatitis and asymptomatic inflammatory prostatitis have not been definitively linked to prostate cancer. You will find some studies that suggest there is a link between chronic prostatitis and prostate cancer. I'm glad because we are part of a study by the trust, the UK Trust, Wellcome Trust for looking at the relationship between prostate cancer and chronic prostatitis, and we hope at the end of the day we will get a solution or an answer to that question. When you come to investigating these patients, it's very difficult, but most of the times you will start with urinalysis and cultures to see if there is a bacterial component. The blood cultures and the blood counts are mainly for acute bacterial prostatitis. But PSA is universal for any patient who presents to you and is of age, who requires PSA assessment, because we are seeing one man of 41 ended up with a PSA of 7, and by the time you're working him up, he had a very high grade prostate cancer. I don't personally do the 4-bottle STAMI test, where you do a DRE and correct the prostatic secretions, because I find it uncomfortable. The yield rate is said to be only 5%, and perhaps you need anesthesia for it to be effective. So I try to avoid the fractional studies. Cystoscopy, if it's indicated, if, for example, a patient on urinalysis have a hematuria, microscopic or otherwise, they may require to have a scope done. So it's only selected patients. And in those who have predominantly voiding symptoms, then investigations of the urethra become important in terms of a MCU or a VUJ. When it comes to treatment, it is dependent on how the patients present. Personally, if they have never received an antibiotic cover, I'll give them an antibiotic for about 4 to 6 weeks. My choice is usually levofloxacin, but we are getting concerns about the resistance that you're getting, because in literature they talk about that and septrin. But when you look at our studies on septrin and the quinolones, we are seeing a lot of resistance to these organisms, and I don't know what in our discussions you recommend. Then the other one, I always put my patients on alpha blockers, especially those with obstructive symptoms or urinary symptoms. The idea is you want to make sure that they are easily emptying their bladders, because like you've said, the propagation of this disease is because when you're having a high voiding pressures that allows egress of urine back forward, it makes amitriptyline, but worked a little bit for those predominantly neuropsychiatric symptoms. Prostatic massage, there's no good evidence to support its use. I don't do it either. And finasteride is only used where it is indicated. I routinely don't give my patients finasteride. Herbal therapy, I have tried. We are all aware about these products like Prostanom, which is actually so palmetto. It also has the stinging nettle as a component and something called PGM. A few of our patients show a response, a few don't. But remember, these patients may be taking your medication plus somebody else's medication. And therefore, assessing who responds and who doesn't becomes a bit difficult. Balloon dilatation and needle abrasion, I've not tried it. Have I had a TUR for a patient with prostatitis? Only one, because he was having predominantly obstructive symptoms, and I think he was 58. These patients are young, and I shy away from giving them a TUR if I can. The other tried modalities of treatment are heat therapy in the form of either microwave therapies, laser therapies, tuna, or high intensity frequency ultrasounds. They are out of our reach. We don't have them. And hopefully they will come to help our patients. That is all I have. Thank you.
Thank you, Dr. D.K. Kimani. Dr. Misango is not going to be presenting his paper. Therefore, the next presenter will be Dr. Ngunyi, aligning guidelines to local practice in BPH surgery. Kindly. Let's try and stick to the 10 minutes. There's a timer. Talk as you try and listen to the warning. We don't want to interrupt your...
Good morning, everyone. My name is Dr. Miro Ngunyi, and I'm a resident at University of Nairobi. I'll be doing today's presentation on aligning guidelines to the local practice in BPH surgery. So what are our objectives today? We're going to look at the elements that form the basis of guidelines, specifically the surgical indications, which surgery you choose, what options are available, and why you choose that specific surgery. And then we're going to look at what we practice locally. And then we're going to see if the guidelines are applicable in our settings or what we can do to make the guidelines more applicable to our local setting. So surgical indications in benign prostatic BPH, the most common indication is LUTS. More than 80% of the indications for surgery in BPH are due to lower urinary tract symptoms, moderate to severe, bothersome. It's recommended that initially you try medical therapy, and if it fails, either due to symptom progression, as failure to relieve the symptoms, or disease progression, or adverse effects, then you can proceed to surgery. But it is not mandatory for you to begin with medical treatment. Surgery can also be an initial therapy in BPH in a patient who's presenting with bothersome, moderate to severe LUTS, as long as the patient is aware of the surgical risks involved. So the second most common indication in BPH surgery is refractory acute urine retention. So it's common in older patients. A patient who is more than 70 years old has a 30% risk of getting acute urine retention, and this is cumulative risk for the general population if they are to live up to 80 years. So it's quite high among the old. Acute retention can be precipitated or spontaneous. It's important because if it is spontaneous, there's a 75% chance that you're going to have to perform surgery for this patient. If it is precipitated, it's likely to alleviate without surgery. So commonly why it can be precipitated, it's in an old person who's taking medication, particularly medications which are used for cold. If it does not have any precipitating, if the acute retention does not have any precipitating cause, then it is likely spontaneous. You have to rule out other causes of spontaneous retention, particularly a stricture. Then you can say that the acute urine retention has been caused by BPH. And then you trial of voiding. If it fails about 1 or 2 times, then you can proceed to surgery. Gross hematuria. It is important for you to establish that the hematuria is being caused by BPH, so you have to rule out malignancy, UTI, stones, among other causes of hematuria. Initial management is medical therapy, and 5-alpha reductase inhibitor, they play a huge role in the conservative management of patients with hematuria. If with conservative management, the patient is still having recurrent episodes of hematuria, then you can plan for elective surgery. If despite conservative management, the patient still has persistent hematuria or has robust hematuria with clot retention, that is an indication for emergency surgery in BPH. So recurrent UTI, bladder stones, and bladder diverticuli, these are signs of bladder decompensation. So there are strong surgical indications for BPH surgery as long as medical therapy has been tried first. So I want to mention something about recurrent bladder stones. In the past, if a patient came in with a bladder stone and had BPH, it used to be a classic indication for surgery. But nowadays, it's possible for you to remove the stones and give medical management. But this depends on the size and the number of stones. if the symptoms of bladder decompensation are occurring concurrently, then it's more likely, it's more favorable for you to proceed to surgery, because you want to avoid the point at which you're going to have irreversible bladder dysfunction. So last, if you have upper tract dilatation with or without renal function impairment, that is an indication for surgery. If a patient has renal function impairment, delay the surgery and optimize the patient for surgery. So after we look at the indications, then we have to look, if you have decided that this patient is going for surgery, which surgery options are available for you. So before we talk about open prostatectomy, I'd like to mention a few things that are important when we're looking at all these various modalities. Number one is efficacy. When we're looking at efficacy, we want to see, after you've done your surgery, can you be able to quantify the effect? And the most, usually Qmax is the most dependable, but it's not commonly done. But Qmax, IPSS, quality of life score, and maybe PVR can be used to assess your efficacy. It's important for you to say, even if this surgical option has efficacy, is it durable? What duration can it last? And what are the retreatment rates? So that's for efficacy. And then we have to talk about safety and tolerability. That is, these surgical options, are they safe? And here we're talking about complications. Common complications that are of interest in the guidelines specifically concern bleeding. That is hemostatic profile. Because bleeding is going to determine a lot of things. It's going to determine your catheter time, your length of hospital stay, and even maybe transfusion requirements. Acute urine retention is also very important as a complication. So is retrograde ejaculation and other long-term complications such as stricture and bladder neck contracture, because they influence retreatment. So we're going to first look at simple open prostatectomy. So this is usually done for large glands. I was hoping Dr. Misango would have talked a bit more about this, but I'm not going to go into details because of time. But what it involves is enucleating, removing the entire adenoma and block. Because remember, BPH is a prostatic adenoma that is collapsing or obliterating the lumen. So if you're able to remove these adenoma and block, then you're going to achieve very good efficacy rates. The problem with a simple open prostatectomy is that it's the most invasive option, and so its morbidity is high. So we have a minimally invasive option of enucleating the adenoma, and this is the endoscopic enucleation of the prostate. This is where you're going to remove the adenoma, but then you're not going to cut. You're going to use a minimally invasive approach. It's done endoscopically. You can either use bipolar energy or laser enucleation. You find your plane, remove the entire adenoma, take it either to the bladder neck or to the bladder, mucilate it, and remove the pieces. So the good thing about it is that it banks on it has the same efficacy as open prostatectomy. And for BPH surgery and efficacy, this is as high as you can go. Now, where it beats open prostatectomy and maybe even TURP is its morbidity, because it is minimally invasive. It's also size independent. That is, it's applicable for medium and large sized glands, whereas open prostatectomy is only applicable for large glands. So it's important to note that the studies that have been done or have been quoted in the guidelines, they've been done by people, urologists who have expertise in performing these procedures. And so the outcomes of this endoscopic enucleation of the prostate, they're really based on someone who has expertise, and surgical expertise is critical to the outcome of this surgical option. The next one is TURP. TURP practical considerations, size and resection time. For monopolar, it's clear. For bipolar, we can push it a little further because it allows us to use under normal saline. It has very superior outcomes in terms of both efficacy, safety, and tolerability, and that is why it's colloquially termed as the gold standard. So alternatives, where they come in is to try and capitalize on some of the gaps that URP has, particularly anticoagulant and antiplatelet therapy in patients who are on this therapy and you cannot interrupt it, then you have a problem, because URP will not have as good a hemostatic profile. Also, retrograde ejaculation rates are as high as 65%. So what options are there to try and capitalize on that? So we have vaporization. What the advantage it does is that it has a better hemostatic profile, and it can be used in even patients who you cannot interrupt the anticoagulant or antiplatelet therapy. So incision or transurethral incision of the prostate can be done, is recommended for small prostates with no mid lobe, and the urethral lift has advantages in terms of preservation of sexual function, sexual side effects, but the efficacy is quite low, and it has very bad irritative side effects. I wish this was clearer, but this goes to show how you choose which surgical option you want to do for which patient. So certain things you have to take into the consideration can the patient have the surgery under general anesthesia? And if yes, are they on any anticoagulant or antiplatelet therapy, and can it be interrupted? If it can be interrupted, then you look at the volume. So when you're looking at the volume, if it's a small prostate, TUIP is the number one recommended because it has better morbidity outcomes in terms of morbidity and similar efficacy to TURP. If it's a mid-sized prostate, then TURP is the gold standard, but enucleation, both bipolar and laser, they come in as a very, very close second. If it's a large prostate, you're seeing we have three number ones. So open prostatectomy and endoscopic enucleation of the prostate. And the guidelines state that open prostatectomy is done in large glands if you do not have the ability to perform endoscopic enucleation. So maybe endoscopic enucleation is the number one recommended for large prostates, but because of lack of expertise or equipment, open prostatectomy comes in as number one. So these are the factors that influence your surgical choice. We've talked about number 1 to number 3. So number 4 is the sexual side effects. If it's a young patient who's intent on preserving the sexual function, then any patient who's going for BPH surgery has to be cognizant of the sexual adverse effects of the surgery. Surgical experience, preference, and equipment availability have been underlined in the guidelines, in that they understand that some of this technology, it's pretty advanced and it's unavailable in most places, and if it's unavailable, you have to give an option to the doctors. So this is a summary of what we've talked about. I'd like to highlight open prostatectomy. As you can see, open prostatectomy, in the absence of endoscopic enucleation of the prostate, is recommended for moderate to severe LUTs of more than 80 grams. The rest we've talked about. So this is showing local practice of BPH surgery at KNH from 2014 to 2020. As you can see, it's an upward trend, and we can even account for our downturn. So in 2017, there was an industrial strike. That is why the TURP rate, the one in blue, went slightly down. In 2020, because of COVID, went slightly down, but not so much. Of note is that in 2020, we were able to do endoscopic enucleation of the prostate in 3 surgical cases. Open prostatectomy rates they're on a downward trend, especially suprapubic, it's hardly ever done. So local studies, so Hemedi et al. Did a study in 2019 looking at the perioperative outcomes after bipolar TURP in KNH, and the conclusion was that positive urine culture preoperatively and advanced age are associated.
Dr. Kimani, you're at 15 minutes.
Yes?
You've done 15 minutes.
Okay. Maybe I can just summarize.
No, just stop.
Okay. Thank you.
I think the sessions are 10 minutes, and let's try and keep it to 10 minutes. We've given him 15 minutes, and at that rate we may not finish our program. We are yet to get somebody who will do 10 minutes. Perhaps Dr. Yvonne? Yeah. Ernest Kimani here. So we are trying very much not to stop anybody. Listen to the timer, Ernest. We don't want to interrupt your talk at all.
Certainly, we are being kind to especially residents to encourage them, but 5 minutes above time is quite a lot of time. Try to practice your presentation in your rooms before you
And then
come here, and then you can always see whether you are going to be done within 10 minutes.
so just get to the point very fast in the introduction and then go to the meat of your presentation. I think that will be able to keep time. And remember, the residents, you're being assessed, and there is a Rita Gobert prize, and timeliness is one of the factors. Thank you.
So, my name is Dr. Ernest Kimani, a urology resident at the University of Nairobi, Year 3. I'm going to present on effects of COVID-19 pandemic on accessibility to surgical care among bladder cancer patients. We know that COVID-19 emerged in 2019 December and has gone on to affect 219 countries with over 112 million cases reported and 2.4 million deaths. In Kenya, over 100,000 cases have been reported with 1,827 reported deaths. So there were measures that came up with onset of the pandemic, and those included lockdown measures, which were aimed at reducing the spread of illness, social distancing. The effect of this on healthcare system was to, especially surgical care, is cancellation of theater services, elective theater services, and mandatory testing of COVID prior to admission for elective theater. And this could have obviously had an effect on accessibility to surgical care. To the patient, this could have resulted in escalation in cost and delay in accessing surgical care. Why are we interested in bladder cancer? We know that bladder cancer has very high recurrent rates, especially it's high-risk disease with a 2-year recurrence rates of 61%, progression of 12%, and mortality of 6.5%. And this is data that is adopted from the SEER medical linked database of the National Institutes of Health in the United States. So with onset of pandemic, we'd expect or we'd anticipate that these changes would increase. Bladder cancer is also known to be the most expensive cancer to manage, and some others have argued that quality and cost concerns are very critical, and it is known to have the highest lifetime treatment cost of all cancers, with in US resulting to over total approximated $4 billion per year. So we did a study. We wanted to know, particularly for this group of patients whom we know their risk of progression of disease is high, we wanted to find out, has the pandemic affected the accessibility to surgical care? And we specifically looked at two things. That is changes in cost and duration of delay to accessing surgical care. So from our study, the mean age of our patients was, we had 39 patients in this study group. The mean age was 53.3 years, with the youngest one being 25 to 84 years. Males were 84.6%, with females being 15.4%. You can, if you look at the distribution of this T stage, the blue and the red lines show TA and T1 stage, whereas the green and the orange lines show T2, that is advanced, and they are distributed more or less equally. When we looked at high grade versus low grade in our sample, 70% of these tumors are high grade, whereas only 30% are low grade. And that shows that our patients are very likely to progress if adequate care is not given. So we also looked at mean time to presentation. Our patients mostly present, the mean duration of presentation is 7.25 months. And when we looked at age versus, when we regressed age versus time to presentation, we found that older patients were more likely to present late than younger patients. And you can see with this regression line, as the age increases, so does the time to presentation increase. Ideally, they should present within 3 months, but I think it's a delay. Most of the patients that were seen in our sample were treated in the pre-COVID era. We don't know whether this is as a result of onset of COVID that made less patients be seen in the post-COVID era. Maybe more data can tell us more about this. In terms of cost, which was one of the key objectives of the study, we found that there was an increase in cost with a p-value of 0.0043, and this probably one of the reasons we could attribute is mandatory testing of the COVID-19 pandemic, of the COVID-19 virus before admission to theater. And if you look at the table below, you can see that most of 36% of our patients paid through cash, 8.3 were paid by cash, and they paid by from themselves and NHF, and 55%. But this does not tell you the true picture, because these patients, even if NHF is going to pay for you, you have to incur cost of testing before you get to the ward. So, and that impacts on accessibility to surgical care. In terms of time accessing, once you are diagnosed, once you present to the hospital, you are diagnosed to have bladder cancer, what was the time to getting a service, that is getting to theater once you are diagnosed with disease? Pre-COVID era, it was 21.25, whereas post-COVID, it was 20.25. And this is a good thing, probably, something to congratulate our surgeons, because despite the ranging pandemic, they didn't let these patients get affected by the disease. In fact, there was an improvement from the point you are diagnosed in before and after the onset of the pandemic. In terms of accessing subsequent URBT, as per NICE guidelines, the mean duration for the entire group was 12 months, whereas for high-grade tumors, it was 13 months. And if you look at this table here, this is the duration, whereas this is the percentile of patients that were seen. The NICE guidelines recommend that these patients undergo the initial TURBT at 3 months, at the second subsequent at 3 months. But you can see over 75% of our patients are already lost to follow-up. That is from 7 months, others going up to even 21 months. That means we have so many patients who have high-grade disease. They're supposed to be undergoing care, but they are lost to follow-up. And in terms of accessing intravesical chemotherapy, we found that compared to pre- and post-COVID era, the results favored the pre-COVID era. With a p-value of 0.012, what we don't know is that were supply chains for drugs affected after the pandemic? Because at the moment, most of our patients are not getting the treatment they require. And we know the value of intravesical chemotherapy. So, in conclusion, COVID-19 has negatively affected the accessibility to surgical care among bladder cancer patients in terms of cost and possibly delay to accessing services. So we need to ask ourselves, why are so many of our patients still lost to follow-up, and what measures do we take to bring them up? And it remains to be seen how the pandemic will impact the disease, recurrence, progression, and even mortality in the long term. Thank you.
Well done, well done. Thank you for keeping time. Nice study. I think point on what we should expound on. Thank you for keeping time. Sorry.
Our next presenter is Yvonne Karimi. She's going to talk on management of female void dysfunction. Yvonne, after doing TARP yesterday on a patient, she calls you Madam Doctor. So probably we should be talking about male voiding dysfunction. After that, we will then have Professor Mungai. We'll talk on scope of surgical treatments in neurogenic urinary incontinence. We'll finish with IDED, and then we'll go to the virtual presentation by Dr. James Van Halsher. Just to remind the people who have cars to remove again, KAV 968A, KCS 174W, KCP 655U, KBQ 951J. You can park these cars opposite Jordan Hospital Medical College, actually Jordan University. It's just opposite the car park, the car wash. There's a car wash with the signboard of Two Brothers Car Wash. Just opposite that is, you can park somewhere. The entrance to Jordan Medical College is there if you remove those cars, please. So Yvonne?
Good morning, everyone. My name is Dr. Yvonne Karimi. I am a resident urology. I'm a urology resident at the University of Nairobi. So today morning, I'm going to discuss about approach to female voiding dysfunction. I'd like to start off by saying the unfortunate thing is that as much as we have tried to diagnose female voiding dysfunction, we've come into a bit of difficulty because no guidelines have been set in the management of voiding dysfunction, especially in women. So voiding dysfunction is defined by the ICS and the International Urogynecology Association as abnormally slow and or incomplete maturation diagnosed by symptoms and urodynamic investigations. That also would point us to like to know what exactly is normal voiding. Normal voiding is a voluntarily initiated, continuous detrusor contraction leading to complete bladder emptying within a normal time span. So female voiding dysfunction is a reported difficulty in emptying the bladder, and it may be due to ineffective detrusor contraction, obstruction of the outflow of the bladder, loss of coordination between the detrusor and sphincter muscles, and or a combination of these two, as studied by Das Gupta in 2003. The EPILET study that covered the greater Europe was an internet community survey. It included 15,861 patients who are all over 40 years, and it revealed that terminal dribbling was the most common symptom at 38.3%, feeling of incomplete bladder emptying at 27.4%, and a weak stream in 20.1%. In the EPIC study, which was also a similar study, 59.2% complained of storage symptoms and 19.5% of the voiding symptoms. Of note is that 8% of the women complained of both storage and voiding symptoms, and 7% complained of storage, voiding, and post-micturition symptoms. So what are our goals as urologists as we manage patients who have female voiding dysfunction? One, it's always to preserve upper urinary tract function. The second goal is also to ensure that there's adequate storage at low pressure volumes. The third goal is also to ensure voiding at low pressures, prevent complications, e.g. recurrent urinary tract infections, which are actually the ones that bring the patients to us, and then to also have socially acceptable management techniques. So as I started off by saying, female voiding dysfunction, managing it can be quite a catch-22 situation because we don't even know where to start when it comes to it, be it the investigations and the management protocols. So we'll start by good clinical history taking. Ask the patient about the past medical history, their gynecology history, how many children they had, whether they delivered CS, whether the delivery was complicated, if they have comorbidities like diabetic mellitus or also multiple sclerosis. And then we can also go to the investigations, which would include urine microscopy, culture and sensitivity. We would also ask our patients to keep a bladder diary for a minimum of 3 days. Ureflometry studies, urodynamic studies, which I believe Dr. Aidid is coming to talk about. Electromyography of the external urethral sphincter and pelvic floor muscles, cystourethroskopy, which could also be able to help us know whether the patient has an atonic detrusor muscle or whether it's a stricture that is there, and also kidney ureter bladder ultrasound. So causes of voiding dysfunction, I am not too sure you can see that, but it can actually be due to abnormal detrusor activity, which can either be an underactive muscle or a contractile muscle. So it can be neurogenic, of which you can be able to define and also put it as either it's suprapontine, pontine, or spinal cord injuries, We have multiple sclerosis, which is the most common cause of underactive detrusor. And then you can also have diabetes mellitus, which also causes peripheral neuropathy in patients who have dysfunction. The non-neurogenic aging has been shown, and that's why it's more common in patients who are over 40 years. And pharmacologic therapy, menopause, because of decreased progesterone levels, and overdistension injury, which I'd like to call out the surgeons for. Kindly, whenever you're post-op, remember to always be emptying your patient's bladder. Then there's a bladder outflow obstruction, which can either be anatomical because of tumors or pelvic organ prolapse, urethral strictures, sling surgery, which will also be discussed by the person coming after me. And it can also be functional, which we have Fowler's syndrome. Fowler's syndrome is actually the hypertrophy of the external urethral sphincter. And we also have Hinman syndrome, which is a non-neurogenic voluntary contraction of the external urethral sphincter during micturition. So management options, we always try to be conservative. We have pelvic floor muscle training. We have biofeedback, bladder training, in which you ask the patient to always be passing urine after 3 hours. We have behavioral modification, ask the patient to monitor how much they drink, 1.5 to 2 liters. We can also have bladder expression, in which you ask the patient to position themselves in different techniques so as to enable them to be able to pass the urine. And we can also have pessaries for pelvic organ prolapse. We also have electric or magnetic stimulation. And what is commonly done, we have catheterization, which should be the ultimate management when all else has failed. And we can have a clean intermittent catheterization or a suprapubic catheter. Whenever we advise our patients to do these catheters, kindly don't let it be a free flow catheter, because when you encourage free flow urine, you're actually causing the bladder to become hypotonic and smaller, reducing its bladder volume. And then now we also have surgical interventions. So when it comes to inhibiting or taking care of the bladder, pharmacological therapy actually exists. We have no effective therapy which increases bladder contractility. We have parasympathetics, which have been discussed, but no study has actually shown any improvement. We have bethanechol or distigmine, prostaglandins, which can be used, opioid receptor antagonist. And when it comes to decreasing outlet resistance, we have alpha-adrenergic receptor antagonists. We have prazosin, tamsulosin, and the like. We have benzodiazepine, baclofen, and botulinum toxin, which is also common. So this is just a diagram of neuromodulation. We'll have to also remember that it's quite an invasive procedure, so we have to walk our patients through that as we discuss it as an option. So what are our future developments when it comes to female voiding dysfunction? Detrusor underactivity could be a target for stem cell therapy to restore the contractile function of the bladder. It is neither experimental, no clinical data is available. In 1970s, we used to have the direct electrical stimulation to the contractile detrusor muscle itself that was developed by Merrill. It had remarkable results, but technical failures and infections were the main drawbacks. So where are we when it comes back to female dysfunction, voiding dysfunction? Diagnosis is still challenging, as voiding and storage symptoms can coexist, but we always ask for early intervention, which is key, and that's why I put my diagram there, because as we always chase our tail, we always feel like there's more behind to what we're leaving. Thank you very much.
Thank you, Yvonne, for keeping time. You had 3 minutes of reserved time. Next speaker, Professor Mugai, does not need any introduction. If we were a politician, we would be addressing him last as His Excellency. So Professor Mugai, please. Professor Mugai's talk is on scope of surgical treatment in neurogenic urinary incontinence.
Yes, as we get this fixed, it's good that we are addressing the topic of lower urinary tract function, because when we sit around in the 2021, you see cows 2021. Cows.
maybe, should we have one or two questions or comments? Dr. Kimani, briefly, prostatitis. I don't know, your peak age is 38 years, and I think even from our patients, we find that most of them are between 30, 40 years. It looks like the data, the reference, had a higher and older age group. I don't know what my colleagues would say or what is their observation. And then if you are to advise us or the residents and everybody else, what would be the best specimen to take? Of course, I agree with you, prostatic massage is difficult to do. And if you want to chase patients away from your office, you just do prostatic massage. It's difficult, you both get tired, you and the patient. Do you do semen culture?
Very loaded questions indeed. One, the literature I looked at talked about a median age. On average, the patients are in their 5th decade, meaning they're in their 40s, which I found odd because when I looked at the patients I reviewed, I found a mean age of about 38 years. Number two, the issue of the semen analysis. I reserve that mainly for patients who have hematospermia as a complaint and pain in the pelvis or post-ejaculatory pain. I always do that. But for the urine specimen, I take a random urine specimen. One of the most frustrating things is that most of the times when you do those urinalyses, you find nothing. And it's very difficult. Sometimes I even wonder whether I should indeed do the urinalysis or having to give an antibiotic irrespective of the outcome of the urinalysis. So sometimes I omit it. Unless the patient has explicit dysuria symptoms, I try to omit it sometimes.
Good.
Very well.
Thank you, Dr.
So I was saying that the management of lower urinary tract symptoms has become a big problem amongst patients with neurogenic bladder, and the increase in the number of road traffic accidents has not helped. And the transition of many patients from pediatric congenital abnormalities to lower urinary tract dysfunction, particularly the spinal bifidus, into adulthood poses a big challenge, and a lot of those patients are lost in our environment. Not lost to follow-up, but actually die because of the poor management of these patients in our area. We have, like I've mentioned, a lot of road traffic accidents and falls from height with a lot of spinal cord injured patients, and that poses a big challenge for us. So the one thing that you find with such a big scope is that you need to choose your size. You may not be able to do every operation that is required for this, and we will need a lot of the urology trainees that we are having and people who specialize in this field in particular, patients who will be able to offer services, people who will be able to make decisions on what happens to these patients. Well, you've got to know what you're dealing with, and that is the lack of bladder control due to brain or spinal cord or nerve innervation. So it can happen in the brain, can happen in the spinal cord, can happen at the nerve level, all of which you have to deal with. So you therefore have to know how the urine is controlled. Yvonne have just been talking about female urinary continence, and you've got to think about the Corticomiculation Center, which is the one that controls what you feel, what you know. You've got the pontine one, which is the level of the pons, and this one you have no control over. And then you have the spinal cord, the one that you will never have control over, and then of course there are the peripheral nerves. So if you look at the Corticomiculation Center, we've said it is in the medial aspect in the brain. The main thing it does is to stop you from leaking urine, and it is at the brain level. And then we have the pontine one, which really controls continence and storage of urine. It is in the it's the micturition center. It's the one that initiates micturation. Then, of course, you've got the spinal cord center, where you have the splanchnic nerves going to, and then to the somatic muscles and the levator and neurons. So the bladder innervation is both parasympathetic, it's got sympathetic, and then you've got the somatic innervation. So, when you're talking about neurogenic bladder treatment, the primary aims of treatment of the neurogenic bladder is to protect the upper tract. The upper urinary tract must be protected. Everything else you do, for those who have studied the Tony Mende diapatic urine, Tony says that the patients will not die of leakage of urine. The patients will die from obstruction of urine. And sometimes it's better to have a wet, living patient than a dry, dead patient. So that is one of the things you need to do. The whole essence of this is you must look at improvement of urinary continence and improvement of the patient's quality of life. The majority of times you're going to be talking about quality of life. And so the protection of the upper tract is a very important goal for you as the urologist. Several muscles must be made to work when you're seated here to hold your urine and to empty when you go to. And the innervation, the nerves, the messages from both the bladder and the brain and the spinal cord in relation to these. If there's a damage to any of these, then you have a problem that we call the neurogenic bladder. The neurogenic bladder, therefore, is not one thing. It's only that this is information going to the bladder. The bladder is the effector organ, but the message is from all over. You have the central nervous diseases, the Alzheimer's disease, birth defects, cerebral palsy, encephalitis, spinal cord injury, etc., and stroke that you must have to deal with. Then you have the peripheral nerve damage, the various neuropathies, the diabetic ones, the vitamin B12, due to surgery, due to injury, and so on and so forth. So, like we said, you must preserve the upper tract function, and that is your goal, whatever you're going to do. You must prevent upper tract deterioration. And what is the cause of upper tract deterioration? It is voiding under high pressure. High pressure voiding is the classical lead to the destruction of the upper tract. The classical risk factors in the upper tract deterioration are the uncontrolled detrusor contractions, like as you find it, this detrusor sphincter dyssynergia, and you've probably seen this, a lot of children, a lot of boys with DSD are labeled as having posterior urethral valves and are treated as such, and sometimes that does not alleviate their symptoms. The care of this neurogenic bladder has been given in many guidelines, and the clear thing that all the guidelines talk about is that the detrusor pressure must remain within safe limits during the filling phase and the voiding phase of micturition. And if you approach this, you will reduce the morbidity in these patients. The treatment must be aimed at primarily at conversion of a high pressure bladder into a low pressure bladder. That's the key aim of the patient treatment. Of course, there is social treatment. The treatment of the social incontinence is also important, but social incontinence is not lethal. What is lethal is the detrusor overactivity or the high pressure voiding. And so, the patients with neurogenic bladder are mostly treated to treat the incontinence, to prevent upper tract dilatation, and those who are refractory to medical treatment are the only ones you offer surgical treatment. So before you think about surgical treatment, think of your medical treatments, and there they are. I don't think I need to explain to you a lot of them. The anticholinergics you know about, the tricyclic antidepressants, sometimes desmopressin, botulinum toxin A, which has its users in this audience, not many. The injection of capsaicin has also come. So the surgical treatment has the aim of facilitating storage. It has the aim of facilitating drainage. And there are maximally invasive options, major surgeries, and there are also minimal surgical invasions, alternatives to facilitate this storage. And botulinum toxin injections and urethral bulking agents and urethral inserts are some of such surgical approaches to it. You also have the more invasive one, the surgical treatment alternatives that facilitate storage, like urethral sling procedures, artificial urinary sphincter implantation, and bladder, neck, and urethral reconstruction procedures as you go higher and higher in terms of invasion of the patients. Others are even more invasive, so you have myomectomy of the bladder, auto-augmentation as it has been called, denervation of the bladder, deafferation, neuromodulation is a little bit less, bladder augmentation, substitution, cystoplasty, and even complete urine diversion from the bladder. So you can also have neurostimulation, which has been used in striated muscle using latissimus dorsi, rectus muscle, and etc. The slings we've talked about. And so these patients, you must think of how to get them. You must make a decision. And the majority of the patients will not have those big procedures. These procedures must be performed only when the detrusor pressure can and is going to be controlled. So you have the spinal cord injured patient. This, if you look at the acquired condition, the spinal cord injured patients, you will not operate on them until about 2 or 3 years, because there is the period of initial shock. There is the shock, total real shock itself, and there is the social shock. And it's only after about 2 years that you meet. And I think the minority of people, I don't know how many of you people here have operated on spinal cord injured patients to control their bladder emptying and bladder filling. That probably doesn't happen very much. So because these are young people, highly motivated, and value their dependence, so they perhaps would have preferred clean intermittent catheterization. So, and it's only when the bladder becomes threatening to the life of the patient should you have to offer them that treatment. You may resect the bladder for a few people who have agreed that they will never do their function. But you must have a urodynamically detrusor sphincter in that. There are many risks in this, and so people have opted to do lesser procedures like inserting stents. You can insert various things, self-expanding stents, and probably this is what is appealing to the industry, that you can put stents to reduce the pressure of voiding. And so, and they're said to be easy to deploy. I haven't used one, and I think the use of this is something that is going to be complicated. But at the end of the day, sit down with your patient, not for 1 day, not for 2 days, perhaps for a very long time, so that you decide what you need. And so lastly, happy birthday to cows on its 25th birthday. Thank you.
Thank you. Thank you, Prof. And your timekeeping is excellent. Thank you. Thank you for that nice paper. We'll call Dr. Aidid here, and then we'll have Dr. James Van Halsher giving us his room talk. Thank you. I think we seem to be conquering our teething problems, and we'll soon be keeping time for the next session.
Good morning, everyone. We're still staying in the pelvis. Oh, sorry.
So maybe as we keep on during this interlude, when we are having the slides being worked on, any burning question to any of the speakers? Yeah, behind Dr. Kimani.
So you go to the end then.
Okay. No questions to any of the speakers? Comments? I think to Dr.
Good morning. Thank you for all the speakers who have attended to us this morning. My question goes to Dr. Ngunyi, not Ngunyi, but Dr. Kimani, who presented about the COVID effect on patients with bladder tumors. In my practice, I thought the biggest effect was the fear of patients to come to the hospital. There was, the government would discourage patients to coming to the hospital, so I thought that was the biggest effect. The other question is, why were there low TURP numbers in Kenyatta National Hospital? The doctor who presented on the BPH surgery.
Thank you, presenters. Mine is on prostatitis, Dr. Kimani. All the points you raised were very good, and indeed that's what we see. There is one I think you just missed, and I needed to highlight it. It is pain at the tip of the penis, glans penis. They tell you I'm having this, and they keep on touching it. And you need to examine and then note that. And then on irritable bladder, I find that people who smoke, and they smoke a lot, they also have that problem of irritable bladder, and of course, is an early sign of cystitis cystica and also early cancer of the bladder. Thank you.
Thank you. Thank you for those questions, Dr. Kimani, Ernest, and DK. You'll be answering those questions soon. I think we give Dr. Edid a chance to go on. Just keep in mind those questions.
Thank you. I wish you had added those minutes to my presentation. But my previous speakers actually have done a justice to the bladder or the lower tracts, and mine will just be actually going through rather than repeating the same things. I'm also just wanted to, of course, acknowledge Dr. Karimi. I think it's good to see our female urologist, and I think you should take up female urology. Earlier on, you should start calling female urology, not urogyne, because that's how they steal patients, and they're never managed for their bladder problems. Thank you. Today, I'm supposed to, of active bladder syndromes, and you can see the ICS definitions, urgency, frequency, and nocturia, with or without incontinence in the absence of a UTI. That's the most important thing that it's done quite a lot in all the previous speakers. These are the symptoms, and I would like to save my time. The lower tracts, of course, suffer a lot. There's a lot of insults. If you can see on your right side, age being one of them, of course, and then anoxias and all that. And on the left side, then you can see the prevalence of overactive bladder as we grow older. This is just a little bit of a physiology. And Prof had actually mentioned this very well, the peripheral nervous system. I'm not talking about the pontine and the cortex, but you can see the other nervous input that control voiding and bladder filling. The bladder is receptive without pressure. That's why the kidneys are safe. The etiology is complex and actually poorly understood. And there are certain hypotheses. There's the neurological hypothesis, where we talk about detrusor overactivity, which is a nerve-mediated excitation of the detrusor muscle. There's a bladder control that's modulated in an inhibitory fashion, just the ones we had presented earlier. Damage to the brain induces the detrusor overactivity by reducing suprapontine inhibition. And damage to the axonal pathways in the spinal cord allows expression of primitive spinal bladder reflexes. The other one is myogenic hypothesis. In this way, the contraction, they result from a combination of increased spontaneous excitation and there is enhanced propagation of this activity. How do you evaluate these patients? There's lower urinary tract symptoms, of course. Those presentations are, symptoms, COVID, comorbidities, conditions, and medications. And just that order been done also. Of all those medications, actually, you have to list them, and those ones which have a lot of input in the lower tracts. Then there's targeted examination, especially the pelvic. Please, residents, learn to to examine the pelvis, especially the female pelvis. Don't just write neg, because everybody knows what neg is, and then look at the urethra, meatal stenosis, urethral caruncles, look at the vaginitis, look at the atrophy, look at all those things, because they will contribute a lot to how you're going to manage. There's also provocative stress testing. We had actually, me and Dr. Kimani had managed to have a patient in Mwingi, which we were doing there, who had been catheterized, I don't know, for quite some time, a young lady of 28. Rectal examination, this also tells you a lot about how the rectum or the anus handles the fecal matter. You're talking about flaccidity of the sphincter, you're talking about fecal impaction, and that tells you a lot about the propagation of the intestinal system. Then there's the urine, of course, urinalysis, urine cultures, post-void residual volume, and bladder wall thickness. For your ultrasounds, always insist to have bladder wall thickness. Sometimes bladder wall thickness is not just because of obstruction. They could be because of the detrusor overactivity. There's voiding diary. Okay. The other ones, the evaluation 2 I wrote there, the diagnosis remains, if the diagnosis remains unclear, then these are the other things that now you proceed to. Conservative treatment at unacceptable risk or even fail. So these are urodynamic evaluation, imaging studies, that micturating cystourethrogram, MRI of the spine, as Prof had already alluded to. You have to to see your spine integrity, and of course, maybe most probably even the brain, and endoscopic examinations. Urodynamic, this is a study of storage and voiding functions. And of course, to remind you, the blood has only those two functions: voids when socially acceptable and stores urine. It is crucial that the UDS reproduce the patient's presenting symptoms, the gold standard for diagnosing blood outflow obstruction and urinary incontinence, a good predictor of outcomes after therapeutic intervention, and it's affected by age, sex, BMI, and anxiety, and that we had already seen earlier on. I think this is the clinical role of urodynamics: characterization of detrusor function, evaluation of the bladder, and evaluation of voiding function. When do you do urodynamics? When clinical evaluation does not establish the diagnosis, is the diagnosis of exclusion. Continence is not restored after the reversal of transient causes. Empirical treatment is ineffective. Surgery is contemplated. Whenever you are doing surgery, I don't think it's not always, but at least we want to know that what you are going to offer this patient is going to change. Remember, the surgery is irreversible. We have seen patients who have been treated as overactive bladder and they had an obstruction. Neurogenic bladder, all neurologically impaired patients with neurogenic bladder dysfunction, and children with voiding dysfunction as well. These are just a bladder diary, which all of you know when you have it in your clinics, and post-void residual volumes. This integrates activity of the bladder and the outlet during emptying. It measures directly by catheterization or ultrasound. When we were residents, we didn't have the comfort of an ultrasound, so we used to do post-void residual volume by catheterization of the patient, post-void. Tell him to go pee, it comes back, and you just put a Nelaton catheter. And actually, it's more accurate than the ultrasound, but of course, it's invasive. Normal post-void is controversial. We normally take 250 as the lower part. In adults of value of less than 25 mil, also that's PVR, where also is controversial. But anything above 50, I think, is good for follow-up. Ureflometry is something also we are all acquiring in our clinics that can estimate the act of voiding and influences the effectiveness of detrusor contraction. Of course, it tells you the Qmax, completeness of sphincter relaxation, and patency of the urethra. The components of urodynamics. Some examples I just give you, like this is a 13-year-old male who had a TB of the spine, fully recovered with residual left lower limb weakness and severe urgency and incontinence. Severe urgency and incontinence. Bladder volume was 90, thickened bladder wall, PVR was negligible. So these are the guys you know, actually. It's a classical of post-void residual volume, a classical of overactive bladder syndromes, where the bladder volume is small and there's no residual volume at the end of it. Then sometimes when you do an MCU, actually, you can start seeing that upper tract deterioration because of the high pressures. please, it doesn't have a laser, but even me who used to do a lot of this urodynamics, you can see I could not even note the electromyography. That's wrong. So the electromyograph should have actually expounded also from the time of the contractions. That yellow, it's okay, it doesn't have, but I think you can see what I mean. That nice electromyograph looks beautiful from the end, from the beginning to the end, but once there was a contraction, the electromyograph also should have shown you that the muscle contraction as well. This is another patient. Normal PSA, he's had large post-void residual of 215, but you can see this guy, everything is stable, just a little bit lower, I mean towards the end, you just see a little bit of a rising of detrusor contractions. And so that you can rule out that this patient is largely more of an obstruction, not necessarily detrusor overactivity. This female urinary loss on cough, jogging, no symptoms of SUI, stress urinary incontinence, grade 3 prolapse. Ultrasound was normal upper tract, but lower tract and lower tract. So volume of 630. It's a large volume, and the post-void was also 120 because of the cystocele, that grade 3 prolapse. Also largely stable muscle. So actually it's highly prevalent. It's an average of 16.9%. The younger age groups, less than 25 years, around 4% or 5%, up to 31% above 65 years old. Both genders have similar rates. Overactive blood of wet are more prevalent of the women, and overactive blood of the dry is more on men. Now, the reason being that the women have relative weakness of the bladder neck and the female urethral sphincter mechanism, especially after giving birth. And you can see there, this is, of course, data borrowed from European studies, and you can see that it's highly prevalent. Overactive bladder affects more than 33 million people in the US, more prevalent than many common diseases, like maybe even diabetes and all that. Total US economic cost of active bladder is around 12.6 billion. Only 20% of the surveyed of active patients are actually extremely satisfied, because these patients, as also been mentioned earlier, they are always frustrated with the treatment. The treatment is not satisfactory, then you keep on trying. Of course, Dr. Kimani also mentioned they shift from one doctor to another doctor, explaining and all that things. And unfortunately, the drugs are the same, alpha blockers, then anything, there's nothing much which will be different. But they know them also, only that they just want to see if they're going to hear something different from another doctor. There's risk factors, there's bladder inflammation, chronic bladder outflow obstruction, CNS disorders, pregnancy, postmenopausal status, and old age. Most of them are like auto and idiopathic. There's also, you can divide overactive bladders into a complicated and uncomplicated, and you can see the list. I would like to keep my time. Am I done? Okay, actually I've also finished. Maybe this hierarchy of management, it's outside my what I was supposed to present anyway, but just to tell you what also others have mentioned, the Botox, PTNS, and sacral neuromodulation organization, all these things are also available in our country. This is AUA guidelines, first line treatment. Dr. Karimi had mentioned behavioral therapies. The second line expected antimuscarinics. Third line may offer botulinum or sacral neuromodulation, and of course the surgeries. And I think that's, thank you very much.
Thank you, Dr. Idid. Thank you very much. I think now we're going to the last paper. Is from Dr. James Van Halsher from South Africa. And he does this on behalf of GlaxoSmithKline, who are our sponsors. And he's going to be talking about early versus delayed initiation of combination therapy and the implication on sexual function. He's given us lectures in Kisumu, Meru, and I think he's known to most of us. And so I think we could go ahead, unless Maurice, you have something to say?
No, not quite.
Dr. James Van Halsher, the floor is yours. Welcome.
Thank you very much to the chair. I hope you can hear me. And I just wanted to congratulate the previous speakers and to congratulate CAS on its 25th birthday. And again, as I've said before, I really think it's admirable, the work that CAS does, and that you are able to pull off a Congress under these circumstances. I would like to share my content if possible, but that is disabled on the screen. I can go directly into the presentation without content, but I think the administrator has the presentation, but I don't have control over the video or content, so I just need access to that, please.
You have the access. You can go ahead.
Right. So really the objective of this presentation is just to very briefly share some recent evidence on looking at the impact of starting medical therapy, and it's pertinent in light of the previous speakers, where the focus has really changed in our urological management from relieving symptoms to being much more aware of preserving lower urinary tract function, particularly detrusor function. And I think that we are seeing this coming up in the congresses like yours and in discussions at the multinational congresses, that we look at this issue of detrusor function, acknowledging the multifactorial impact on bladder function as patients get older. But we are able to address one thing, and that is bladder outlet obstruction in our aging patients. We need to choose an intervention with disease-modifying effect, therefore either a medication with disease-modifying effect or surgical intervention to disobstruct the lower urinary tract when we have evidence that the bladder is obstructed. I'm going to present some evidence which looked at a meta-analysis of over 10,000 patients who were all at increased risk of progression by commonly accepted definitions. And this meta-analysis looked at two outcomes. They looked at the clinical response rate in terms of IPSS, so in other words, in terms of symptom improvement, and then the incidence of acute retention and surgery over a 4-year period. This was first published as a paper in the World Journal of Urology in 2019, and the study endpoints were around meaningful improvement in symptoms, that is an improvement of 25% or more in IPSS at month 48, and then the other study endpoints listed here. This paper used innovative methodology of drug disease modeling and then clinical trial simulation, but in essence, it's a meta-analysis of a large number of patients, put together a database, high quality, homogeneous data, and this comes from previous clinical trials on patients at risk of progression. The headline findings were really aimed at looking at the timing of intervention. So there's limited data that we have which indicates that early intervention with disease-modifying effect has better outcomes than delayed initiation. There have been some retrospective database studies, but those have limitations. But there really is limited data to indicate what the timing of therapy would be. And this study looked to assess systematically what the timing of combination therapy using 5-alpha reductase inhibitor and alpha blockers would be if you started immediately, or if you started combination at 1 month, or at 3 months, or at 6 months, 12 months, or 24 months. The headline findings were if you initiated combination therapy immediately for patients at risk of BPH progression, they had a 79% responder rate as opposed to a 65% responder rate for alpha blocker monotherapy over 48 months. It's interesting that the quantum of difference between those two, from 65%, which is quite a good response, but not as good as 79%, the quantum of difference was exactly the same quantum of difference found in the COMBAT study, showing that the methodology and this clinical trial simulation was actually a solid model, and this was validated. If you delayed initiation of combination of step up to 5-alpha reductase inhibitor, and therefore combination, by 1 month or 3 months, there was no statistical significance. But from 6 months onwards, you started to see a decline in responder rate. Perhaps more impressive than that was a time to event model looking at the same database of just on 9,000 patients. They cleaned up the data a little bit, looked at 9,000 BPH patients, and then looked at the incidence of acute retention or surgery depending on the timing of intervention. So look at the bar graph on the left-hand side. So immediate initiation of combination therapy over 48 months, specifically in this cohort of BPH patients at risk of progression, 4.6% of those patients either went into retention or required surgery over 48 months, as opposed to alpha blocker monotherapy over 48 months, 13.3%. I think this is of real interest to those of us who work in the public sector, where we really want to avoid this burden of catheterized patients and patients waiting for surgery. If you delayed initiation of a disease-modifying effective 5-alpha reductase inhibitor by 1 month or 3 months, although there's a slight increase, that wasn't statistically significant. But from 6 months onwards, this starts to look very different, and you see that stepwise increase in complications. And this is really a reflection of ongoing disease progression as a result of prostate growth. We know that the prostate grows by 4.5 to 5% per annum, and you're starting to see that reflected if you allow disease to progress or prostate growth to increase. As one of the other endpoints of the study, we looked at different categories of improvement, and substantially more patients showed improvement from severe symptoms to mild symptoms if they initiated combination or including 5-hour rise early as opposed to late, and that early now is a period of less than 6 months. So we had some insights from the study, the insight that immediate response to alpha blockers is not predictive of long-term improvement, although we are all familiar with patients doing quite well on alpha blockers over a long period of time. In patients at risk of progression, that effect tends to fade. And really the headline is that this early use of combination with the disease-modifying moiety of a 5-alpha reductase inhibitor, which shrinks the prostate, it's the only drug class which has evidence to show that it has this effect on BPH. The rest of address symptoms, results in this larger proportion of patients having greater clinical improvement. So that's the one side. I think that this fits in with our intuitive understanding. But the other side of this story is, what do we expose our patients to, and the perennial concern around sexual dysfunction. So we know about the link between BPH and sexual dysfunction. For the trainees in the audience, I would really refer you to Rosen's iconic multinational survey of the aging male, published in European Urology in 2003. That is an excellent study which looked at the correlation not only in the aging male and sexual dysfunction, but particularly the relationship between lower urinary tract symptoms and sexual dysfunction, and showed that in a stepwise fashion, the more severe the patient's lower urinary tract symptoms were, the more prevalent erectile and ejaculatory dysfunction was. But there are very few prospective randomized clinical studies which actually look and assess this and study this. And GSK did a study which was randomized, it was prospective, and it was done in men with BPH at increased risk of progression. These were men with a median prostate size of 50, men with an IPSS of approximately 16, and all of these men were sexually active. And that's really important because we know that not all men in this age group are sexually active, but these men were sexually active. I want to just go through some of the findings from the study. I'll put up all the lines and then I'll explain what it was. This study used a validated questionnaire which assessed all aspects of sexual function. It assessed libido, it assessed erectile domain, ejaculation, orgasm, overall satisfaction in these men. And what the graphs show here, these men could score a potential 85. If they had perfect sexual function, they were totally satisfied, they could score 85 out of 85. The mean score in the study was 62. So these men were quite good, but as you would expect in an older male population with BPH, their scores weren't perfect. They averaged 62. Over a period of 1 year, 243 patients were put on a combination of dutasteride and tamsulosin, and 245 patients were watched on placebo, and their sexual function was monitored. There was only one domain which showed a significant decrease, and that was in the ejaculatory function, where there was a substantial decrease in their points by 7.5 points. So these men went down from about 62 to about 52. They didn't go to 0. Erectile function, which are the top lines, were unaffected, and overall satisfaction and libido, although they showed a small decline when you see it on the graph, not a mean adjusted, but the actual real decline. There were declines there. They were statistically significant, but they were thought not to be clinically meaningful, and these authors included Roborn and Rosen, who had done the original multinational survey of the aging male. So a very interesting insight from the study is that the erectile domain appears not affected by 5-alpha reductase inhibitor. That goes against what has been thought previously. There is some supporting data. There's a large database study from the UK, from their clinical research database. There's also a large study that came out of Russia with 300 patients on a combination of 5-ARI and anticholinergics, and that study showed no impact on erectile function. And so that's an interesting insight as to this perennial concern around what we are potentially exposing our patients to and impacting on sexual function. And this is not to diminish the importance of sexual function in our aging male. Whatever sexual function they have is critically important, and we don't want to impact that. But we do know now that this combination therapy predominantly affects the ejaculatory domain. For some patients, that is a concern and a bother. I find that when I counsel patients, I explain this, the patients understand it, and as long as erectile function is maintained, they are generally satisfied. But you do have an occasional patient who wants to address this, and in that case, there are strategies that you can adopt, and we can talk about these. So we go on to really considering the hard questions. As a clinician, listening to this as a urologist, seeing patients on a daily basis, some of the hard questions that are coming up. If I start early 5-alpha reductase inhibitor, so I'm here as a GSK person, and I'm talking about starting these drugs. Is this purely motivated by the interest that I have and the declared interest as a GSK person, or is this genuine? Well, I think the treatment effect and the beneficial effect in addressing disease progression is well established now. There are high quality studies, and this is reflected in the guidelines. In terms of impacting on sexual activity, I want to put a thought to you that if BPH is so closely correlated to sexual dysfunction, and we address BPH proactively with disease-modifying effect, are we compromising sexual function, or are we potentially protecting patients from the ongoing growth of the prostate? That question is not answered anywhere in the literature as far as I'm aware, but we certainly do have an impact on ejaculatory function. And this goes to the second question: what can I do to improve sexual function in a patient on alpha blocker and 5-ARI who complains? I think the first thing is to really establish, what is the patient complaining of? Are they complaining of erectile dysfunction, or are they complaining of ejaculatory dysfunction? If they're complaining of ejaculatory dysfunction, you can certainly withdraw the alpha blocker component. We know that this is class effect of the alpha blockers. withdraw the alpha blocker component, but I would make a request to maintain the disease-modifying effect of the 5-alpha reductase inhibitor so that the patient doesn't go on to progress, although you have symptom control, but they are not going on to progress and potentially compromising their detrusive function. If the patient has erectile dysfunction, I think it's perfectly valid if a low-dose PDE5 like a tadalafil 5 is registered in Kenya, to start on a daily tadalafil as well as the 5-alpha reductase inhibitor and see how the patient goes. And I think that patients are generally very satisfied on that combination. The quality of their erection improves, their lower urinary tract symptoms improve. Tadalafil has a positive effect on nocturia as well as the dutasteride, so that's a good combination. The third question I wanted to address is testosterone replacement therapy contraindicated in a patient on 5-hour rise? And there's a particular reason why I put this hard talk question in there. This question was raised in a webinar with Kenyan colleagues, and I was poorly informed, and my answer was that I wouldn't believe that there's a rationale to have simultaneous testosterone replacement therapy and 5-alpha reductase inhibitor. They would work against each other. That was really lacking in insight, and I need to retract that comment. I then went to Professor Shingai Mutambirwa and discussed this with him. He said, no, these are not contraindicated. Obviously, these work on different pathways. Your 5-alpha reductase inhibitor works in the prostate and inhibits the conversion of testosterone to dihydrotestosterone, but that shouldn't adversely affect the therapeutic effect of testosterone that you're giving. So no, there is not an obvious contraindication that he was aware of. And when I look in the literature, I don't see an obvious contraindication. So I needed to address that, and I hope that that's useful to you in clinical practice. And the last point is, what is the recommended treatment duration for combination therapy? Very briefly, there's no point in starting combination therapy unless the patient is committed to long-term therapy. And initial therapy should be a year before you start to see the full benefit of the 5-alpha reductase inhibitor. So this is long-term therapy. Thereafter, we have data, and very good data over 48 months to show benefit. But in clinical practice, you're going to be reassessing the patient on a regular basis, and as long as the patient has adequate symptom control, report symptom control, and you as the clinician are satisfied that the patient is not running into problems with BPH disease progression. Previous speakers have spoken about post-void residual volume, bladder wall thickness, the patient's stream, and the overall quality of their low urinary tract function. You can continue until the next time you assess the patient, and there isn't a specific cutoff. I hope that this has been useful clinically. I hope it's been relevant, and I hope it's given you and shared some insights from a large database analysis, meta-analysis of the impact of timing of combination therapy, if that's a consideration for you when you see your patients. Thank you so much.
Thank you, Dr. Van Halsher. Probably that brings us to the end of this first session. But before we end, we will just quickly go to the two questions that were asked by Charles Waihenya and Brigadier Waweru Mato. If they can just repeat those questions to the presenters. Kimani?
Yeah, I think I got Dr. Waweru's question. He was asking, he was putting a comment that most patients with prostatitis that you see, the pain is at the tip of the penis. I tend to see the opposite, where the pain is more at the base of the penis and in the region between the scrotum and the anus, with some complaining of testicular pain and suprapubic pain.
Next.
Ernest Kimani.
Yes. It's another presentation. Agreed. Thanks.
Thank you for asking the question. He was putting a comment that perhaps patients visiting to the hospital was discouraged with the onset of the pandemic, and that explains probably why we had more patients who were seen for initial TURBT in the pre-COVID era than in the post-COVID era. But in bladder cancer, we cannot afford to ask patients not to visit the hospital, because we know that the risk of not having these recurrent procedures will result in increase in progression, recurrence, and even mortality is increased. So I think in this sense that the patients who are advised not to visit, it's a possibility to explain our results, but again, it is totally unacceptable in treatment of bladder cancer. Thank you.
Professor Mungai.
I think just to add on what Dr. Kimani has said, if you note in that graph, there was a general reduction in all operations, and I attribute this to travel restrictions. You remember we had very stringent travel restrictions. Most of our patients we treat at Kenyatta National Hospital are from all around the country, and because of the restrictions, they could not access the city. That probably explains that, Dr. Wahenya.
Just give mic to Professor Mungai, please.
Thank you very much, Chairs. We've had this talk from Dr. James Halsher, and him and I have gone on this before, and that is the effect of the combination therapy on patients' erectile function. What I've seen, and because in Kenya patients tend to move from one doctor to the other, when I've seen patients from colleagues, I see them combining the combination therapy with a PDE5. And true to that, in my office, patients who I don't tell, or I forget to tell that there will be an effect of the combination therapy on their sexual function, either by forgetting or not having enough time, come back and tell me, does that thing have an effect on erectile function? I think we need a study for both Kenya and South Africa on this to see what happens to the real patients. I'm just beginning to think that what we are talking about doctor-reported outcomes in those studies rather than patient-reported outcomes. I don't know what Dr. Halsher has to say about that. Thank you.
How can we link to...
Thank you, Professor Mungai. Do you want me to respond?
Yes, please, James, just respond, yes.
Yes, thanks very much, Prof. It's a very good point. I think that what was good about the sexual function study I presented was that, you know, this study used a really careful, validated questionnaire which assessed these different domains of sexual function. And I think that something does get lost in our communication with patients, either by omission or by what the patients raise. And I think when we establish a baseline at the first visit, what is it about the patient's baseline sexual function and what is it about their expectations? I think we go a long way towards clarifying where we are with the patient. I have, like you, I found that patients who are taken by surprise about the impact, particularly on ejaculation and orgasm, they are taken aback, and they say, you know, what is going on here, because things are not the same. When we explain that to them, or when we explain this is how the drug works, it blocks the muscles in the bladder neck, blocks the muscles in the ejaculatory duct and the prostatic musculature, and therefore the force of ejaculation is going to be reduced. They are often accept that, but this is, you know, if we are talking about erectile function, I think we are actually seeing more and more real world evidence from that large database study in the UK, which is tending to point to the fact that 5-ARIs are not implicated in erectile dysfunction. I think that these patients are exposed to risk factors, or a multitude of risk factors, but perhaps the 5-ARI is not the smoking gun that we expected. But if we're going to study this, we need to use really good tools which enable patients, and this would be a patient self-administered tool, the male sexual health questionnaire, but it's detailed, it takes a long time, and using that would get a really good baseline if the patient can go through that process.
you. Perhaps one last question?
Can I just ask Van Halsher one question? Van Halsher, you mentioned about a patient in combination therapy. If he has got ejaculatory dysfunction, you remove the alpha blocker, and the erectile dysfunction, you remove the 5-alpha reductase. What about if he's having both? What do you do?
Yeah. So I would advise, if the patient comes and complains of erectile dysfunction and they're on combination therapy, that it's a good combination to use the PDE5, a daily PDE5 like tadalafil 5, and the 5-alpha reductase inhibitor. I really do believe that there's not good objective evidence now to suggest that the 5-alpha reductase inhibitor is the direct cause of the erectile dysfunction. And I think if you start the patient on the PDE5 in combination with the 5-RA, you're taking care of two things, both the BPH symptoms, the BPH progression, as well as enhancing erectile function. And you need to look at other risk factors for erectile dysfunction in that patient.
Probably.
Thank you. Thank you. Last question, Dr. Mito?
Yes, it's just a contribution to the ongoing discussion. We had a study in Kenyatta about the same, though our study population was not quite as large as to give a definitive answer, but medication was positively associated with erectile dysfunction. And actually 56% of the patients were on combination therapy.
Okay, thank you. I think, thank you, ladies and gentlemen. This was a hard session to chair. Of course, we had some teething issues. It's now officially a hybrid meeting. We've had the first Zoom and a couple of physical papers. Thank you very much for your attention, for your contribution, and for the good papers. I think we'll ask I think it's tea break. But let's bear in mind that the next session is supposed to start at 11. It's now 11 o'clock.
Just remember to visit the industry,
yes,
the exhibition, and so we come back in time.
And you can now move your cars if you must.
Oh yes, just the cars again. KAV
11:30.
960. KAV 968.
So let's be back here. So we're back here at 11:30 or 11:20? 11:30. Sharp. Let's manage time, please. Thank you.
Of course, the governor will not make it, but she is supposed to send a representative. We shall give you a briefing on that as soon as we have more information on who will be here with us. Okay, I'm being informed that the CEC of Health is on the way coming. So to moderate this session is myself, Dr. Francis Osawa, and Dr. Matu. So I'll hand over to Dr. Matu to begin the session. Thank you.
Thank you very much. Good morning, everybody. I think we can now let Dr. Samnake do his presentation. It's a virtual presentation, and I think it's ready. Dr. Samnake, you are free to go ahead.
This one. Hello, good morning.
Good morning.
Do you see my screen?
Not yet. We are not able to see it yet, Prof.
Now?
Not yet.
Now?
Not yet. Not yet, Dr. Ari.
We can see you, but not the screen, please.
The center. The center.
Which one?
The share screen button at the center.
Yeah, I'm trying to. I don't see it, unfortunately. It's not appearing here.
Professor Samnag is tomorrow to talk about wet labs and the trainers in endo-training urology. IT has some challenges sometimes, so let's give him time so that he can put his house in order, and then we can move on from there. I'm sure he'll be able to do it.
The center button there is a share screen, a green.
Yeah, no, I can't see it, unfortunately.
Yeah, sorry?
I can't see that.
Have you opened your presentation first?
We had just done it earlier. Can I get out of this?
Professor, is a secretary there? Maybe she can be able to
Yes.
sort it out, please. It might help us.
Yeah, she's here. She's here. In fact, we had already set it up. It's just that
All right.
it has become a little. Let me end this show. I'm coming to your Zoom meeting. So.
Okay. First of
I can see you, but I can't get onto the Zoom thing.
on your screen, on the Zoom screen at the center, there is a share screen button. When you select that, you will be able to see your presentation and select it.
Yeah. Okay. Okay. Now I can say share screen.
Yes.
There. Okay.
Good. Then
Is there?
slideshow. Good.
Okay.
Yeah, you're good.
Okay, so I can. Okay, so can I start?
Yes, Prof, you can go ahead.
Okay. Good morning, everybody. Apologies for that delay. At the outset, I would first like to congratulate the Exco of Cows and the program organizing committee for carrying out this beautiful week of urology. I know it has been trying because of strikes and other things, but I had rung Dr. Matu yesterday, and I believe that you've had a very good workshop, so congratulations on that. Secondly, I would like to thank Cows and the program organizers for allowing me to talk on this subject. So the title that I'll be speaking about for the next 5 to 10 minutes is Wet Labs and Endo Trainers in Urology, in endourology training. There's no conflict of interest to declare. And straight off, let us start with what we mean by wet labs and what we mean by dry labs. And a wet lab is really, it means what it says, something that is wet, liquids. And when you focus on those liquids, we can see that they include activities that include tissue culture, pathology, cell biology, liquid analysis. You can have additional features in terms of drain and vent services. And also, you can have lots of research done on environment in the wet labs. As opposed to that, a dry lab is an environment focuses on computers and mathematical analysis. So there is no liquid and no wetness involved. And you can see the usage of this can be in calculations, primarily to perform computational or applied mathematics, laboratory equipment, computer-assisted experiments, and of course, the big thing is cost effectiveness and accessibility. So by definition, what we are going to limit ourselves with is wet labs. We talk about liquids. In terms of medicine, we talk about animal tissue, and we talk about whole live animals as well. And as far as our dry lab is concerned, we have our endo trainers and they involve use of hardware and software. So I'm going to make a rather sweeping statement, start with a sweeping statement here, made by, in an article by Hamad Akhtar and Tamina Siddiqui in 2013, but I think it still applies to us at the moment here. And it says that despite producing some of the leading urologists in the world, urological training in the developing world is marred by inconsistency, lack of structure, and evidence-based practice. Now, this is a pretty sweeping statement, but I will try to justify how we can counter that. We are all being trained as the Halstedian model in the past. This is the model that we have been using over centuries since the onset of medicine, especially since the onset of surgery, that you see a procedure, you assist with one, you do one, and you teach one. And unfortunately, you can see from this first statement that to be able to at least get to some point, you have to deal with 4 patients to be able to try and understand what you want to do and how you want to pass on the skills from one person to another. In the current state of endourology, this model cannot be sustained. Why? First of all, there is a huge learning curve. If I go back to my days in Liverpool, when Tony Desmond asked me to look through an endoscope when he was doing a TURP, he made a groove at the 7 o'clock position, and then he told me to look inside and said, "Do you see that groove?" All I saw was blood, and because he was the boss, I said, "Yes, I see the groove." And you know the pitfalls of that. Things improved when cameras came into view, and now we could see things much, much better on the screen, and everybody else could see it on the screen, and so the learning could be better. But in spite of endoscopic development, and in spite of visual aids and advances, I still feel that the first 5 years of doing TURPs, for me, I feel sorry for the patients. I did them because I didn't do them well. I think we can learn even from the camera that it takes a little time to learn how to do operations, be it a TURP or a DVU or whatever, in a good way. Why else does the Halstedian model doesn't work? It doesn't work because of working hour regulations. In the old days, when you were a registrar and senior registrar, you had to be in and around the ward 24 hours for a few days, get a few hours off for sleep, and do that until you qualify. Nowadays, the governments have laid down regulation for certain hours for the junior doctors to work. Therefore, that decreases their time for learning, and therefore increases the learning curve. Again, working too hard and working too long can diminish your ability to make decisions, and patient safety issues are at hand in the sense that you might perforate, you might injure a vital organ, you might cut a vessel. These things all get affected with the type of stress and workload you have. Increased litigation. The public has become very aware to this, as we all know, all over the world, and they always look for a chance to litigate, but we don't want to give them a good chance to litigate, so that we need to cover ourselves adequately. And finally is the old issue of patient volumes and case mix. You need to have enough number of patients, you need to have a good number of case mix to satisfy everybody, to make sure that everybody gets their share of learning of certain procedures. So what is the solution? The solution is simulation. And this has become a pretty good, effective tool to counter the problems that I have just mentioned. And to understand that, I need to define simulation so that we are on the same page. And you can see it is a big sentence, because it is not just simulating for the sake of simulating. It's a technique to replace or amplify real experiences with guided ones that evoke or replicate substantial aspects of the real world in a fully interactive manner. There's a lot going on in this sentence. It's not that you send your resident off to a lab and say, go and practice a DVU somewhere and come and tell me what has happened. No, that is not what happens. The materials that are used for simulation must, by definition, mimic the true thing, the true human body. Therefore, things like, for instance, if you're doing, I take prostate as an example, because it's the easiest one. When you have in a simulator, the material which simulates the prostate should feel like the prostate when you're cutting it. It should bleed like the prostate when you're cutting it. It should stop the bleeding when you're applying the diathermy to stop the bleeding, etc. And secondly, simulation must also be integrated into the curriculum and encompass education and principles like education principles like feedback, practice, mastery, and outcome measurement and maintenance. I'll be talking about this in my last slide. So when we talk about urology, what are the minimal accesses we are talking about? It takes me back to 1986 when I went for a course in urology at the Institute of Urology at Shaftesbury Avenue in London. And on Professor Wickham's door was a big title of his which says, Department of Minimal Access Surgery. And I said, man, these guys are always looking for new things to happen. They're not happy with their title of consultant. They're not happy with the title of professor. They now want to be champions of something called minimal access surgery. And that was my thinking in my younger days, and how wrong it could be, because this has now developed into a whole big program and a whole big item by itself. So in urology, what we need to concentrate on this topic is the laparoscopic way of dealing with operations, the endoscopic way of dealing with operations, and the access to robotics to do surgery. And if you think that the world of endoscopy and minimal access surgery and trainers is limited to urology, let me just tell you that neurosurgery, ENT, plastics, anesthesia, cardiovascular, thoracic, laparoscopic, gynae, uro appears there, prostatic surgery, etc. All these subspecialties in surgeries are actually on the bandwagon of trainers and simulators. We are not unique. So you'll be surprised, or you might not be surprised if you've gone onto the internet and you've just Googled simulators and trainers, that there are so many companies that are actually in the manufacturing of this equipment. There's a variety of them. There's such a big choice. It's just unbelievable. So urology, for instance, we can start, when we train our residents, we can start with simple procedures like cystoscopy and elevate it to TURP and urethrotomy, proceed to endoscopic surgery for ureteroscopy and venoscopy, graduate further to percutaneous nephrolithotomy, graduate even further to radical prostatectomy or radical nephrectomies, and then the urinary diversion procedures and lymph node dissections for cancer surgery. So, having said that, what is the local scenario? Is there a question?
Kindly summarize, we are running short of time.
Yeah. Okay, so what is the local scenario? Here we have the Surgical Center in Nairobi, run by Johnson & Johnson and the University of Nairobi. This consists of a wet lab for cadaveric tissues and a dry lab for as a laparoscopy simulator. That is a porcine model for laparoscopic cranial that we have there, and that is a wet model for a Bari flap bovine bladder ureter injuries. So what are the objectives that I need to emphasize on for ourselves? Number one, the issue of endourology and training must be incorporated into a proper curriculum. When a curriculum is made, it's not only what we need to do in terms of the didactic training, but this should be included into the objectives of a training program. The resident needs to be assessed on what he does, therefore he has to be supervised and must have a log bag. There has to be a feedback process to the resident after procedures have been done. There has to be a monitor of practice, both for the teachers and for the learners. There has to be updating of skills because things will be, sorry, not things, but instruments and techniques and monitors and everything changes. The big issue of equipment maintenance and upgrades is essential. And unfortunately, the major challenges that would be inculcated or seen by us are cost and space. So the future considerations, we are now thinking of, I know that the ERK building is already coming up. We're expecting the Urology Center for Cows at some stage in a few years. And my appeal would be that this is absolutely the right moment for us to actually properly develop a dedicated department for endourology, and apart from getting our towers, getting equipment for simulators for endourology prior to our residents' intake. Thank you.
Thank you very much, Professor Samnake, for that nice presentation. We're going to allow 2 questions to Professor Samnake. If anyone has a question or a comment, please go ahead and do it. Meanwhile, Dr. Oyeko, prepare for your presentation. Any question or comment?
Yeah. Prof. Mungai, yes.
Thank you very much, Said, for that presentation on what we need to have. Kenya is growing, and the urological needs for this country are getting bigger and bigger. And we shall need to have 1 or 2 centers that helps people gather the skills that you have alluded to. The big question about such a center is ownership. And may I probably think that such a center is best owned by the public sector because of the costs involved in setting up such centers. Where therefore, Said, shall we direct our energies in terms of having a center that can provide for training for people who come from Mombasa, come from Kisumu, come from Mandera, and indeed even from Nairobi? How do we get this to work properly for all Kenyans without leaving some Kenyans untrained because of lack of resources? Thank you.
Thank you very much, Peter. Mr. Chairman, can I answer?
Yes, proceed, Prof.
Yeah. Thanks, Peter. I think I want to throw this back at you. I think we are very, very lucky that we have you as in the leadership of the ERK program. Now, obviously, because of the cost implications, we can't have centers at each and every place, each and every town in the country. But I'm sure that even if we have a single good training center, we can allocate time for usage of that center for various urologists and trainees across the country. It's like booking a session for 1 week for urologists from Kisumu, 1 week from urologists for Mombasa, etc., etc. And also for the training ground. So I don't think there is cost implications, but if we get one started, we can share our resources in an organized way, in a booking way. I think we can do that. And I think with people like you in the leadership at the moment, probably it behoves on you to make that suggestion at your meetings next time.
One of the challenges I've encountered is that the residents are not very keen to use endo trainers, because in the Kenyatta National Hospital, we have actually set up a small endo training unit. I would like to ask one of the residents, you see they're looking at me surprised that there is one. Let me ask one who was the chief resident. Where is Amadi? maybe to make a comment as to what is preventing residents from using these endo trainers. Okay.
Probably maybe access to the endotrainer itself or lack of knowledge that it exists.
You need to speak up.
Okay, he says lack of knowledge that it exists, and lack of access. Maybe I'll announce here today that we have a dry lab on the ground floor of Kenyatta National Hospital. The key is to the dry lab is usually with the nurse in charge. And I'm sure I've announced this before, but I'm announcing again that these endo trainers are there, so you can start using them. Thank you.
Mr. Chairman, can I respond to that?
Please do, but be very brief.
Yes, I'll be very brief. Mr. Secretary, I think that is the exact problem. I mean, even I was not aware of that there is a dry lab there. I thought the only one was at Chiromo. You see, the issue is it should not be there for a resident to pick up a key from a nurse and walk in there and do what he wants. That is not endo training. Endo training has got to have its own guidelines and curricula. The person going in there has to be supervised. It has to be recorded. A logbook has to be filled and a feedback has to be given. That's where we need to head towards. Thank you.
Thank you very much. Our next speaker is Dr. W. Oyeko. Oyeko is a lecturer at Maseno University. He's a consultant practicing at Kisumu Specialist Hospital and Aga Khan Hospital. You have 10 minutes, please. Proceed and try to save time. Thank you.
Morning, ladies and gentlemen. I want to thank the organizing committee for having given me this opportunity to present this paper, which is very relevant to our practice. Urology practice is our business. That is our business, is urology practice. So there are different types of urology practice. We have solo urology practice. We have group urology practice. There is multi-speciality group practice. And of course, there is employment and contract. As you can see from this diagram, you'll see that the solo urology in this survey that I did, 47%, about 47% are in solo urology. Then group urology is 0. Then group multi-speciality, we have 9%, and people who are on permanent employment or contract are about 10%. What does that say about us? And where is the world going as far as urological practice is concerned? What are the values of hey, this thing is sorry. What are the values of group practice? In group practice, you have improved patient care, you have information sharing, you have practice management tools, clinical trials, benchmarking, and other innovative resources. You've got proactive government relations, large patient population, analysis of patient statistics, guiding in selecting better treatment modalities. At the same time, there is cost and administrative standpoints. You share financial risks and practice burdens and offers economies of scale. There's less administrative hassle and there's more time, there's more free time. If you can see from the diagram that I've just put up, you can see sorry. This is people who are working in hospital-based conditions, and these are urologists who are practicing outside the hospital, and about 1% practice within and out of the hospital. So you find that the majority of us are practicing within the hospital premises. How about single specialty versus multi-speciality? What is therefore preferable? 4%, and permanent employment is 47%. So if you are in solo urology practice, you can see that the amount of money you spend on equipment drains you dry. But you are in practice also to get something to take home for your family. So we are not supposed to work just for the industry, but we are also supposed to work for ourselves. How about the hospital employment situation? The hospital employment situation takes away burden of running a practice. There is income stability. However, what agreements you had with the hospital, you are sure at the end of the month you can get that money, and of course you can plan. You have access to advanced medical technologies and treatment options. There's opportunity to assume an existing patient base, and there's opportunity to participate in clinical research, and of course you are assured of your annual leave. But with hospital employment, there's limited term of employment, maybe 2 to 3 years contract, and these contracts you have to negotiate them. And most of the cases, the negotiation does not favor the urologist. And also they put for you different payment modalities. They can set for you a minimum gross and a maximum gross. So if your maximum gross is 500,000 and you make for them 2 million, they'll still pay you the 500,000. So it is also not favorable. So, in my conclusion, I would say success in today's healthcare climate is collaboration. In employment, you get exactly what you put in. With the changes in healthcare management, devolution, NHIF setting goalposts, other instances tightening their other insurances tightening their passes, the future of solo practice is bleak. With the country's debt burden, COVID pandemic still ravaging, and rampant corruption at the central and county levels, whether in group practice, employed, or solo practice, you have to increase your efficiency and reduce your costs. As you can,
time is up. Just summarize, please.
I've shown you this before, and it's actually shows you how solo practice is not advisable. And with the young urologists coming up, it is advisable that we go into group practice so that when they qualify, they can come and join the groups so that they can survive in this difficult field. At the same time, there is another way of practice which is coming up. a group of specialists can go to a hospital and set up a practice within a hospital, and it works well, whereby you can get a urologist, you can get a neurologist or a nephrologist working together within a hospital. So they have a base, they have equipment, and it works well for the urologist.
Mr. Ayako.
Okay. Thank you.
Thank you very much, Dr. Ayako, for that insight and voice. But let's try to keep time, others going to be in problems. Just a comment. We are very keen in keeping traditions, and we are always scared of changes. The advocates never practice alone. You see, so and the company advocates. Essentially, most of them. Even when somebody has no partner, he calls himself Matu and the company advocates and is alone. He's anticipating to get a partner later on. How lawyers have beaten doctors that practice and game, we don't know. I think we need to learn from them. The time for one-man show is running short. We must know how to invest as a group. A simple question. Why aren't the hospitals in Kenya quoted in Nairobi Stock Exchange? Is there an hospital quoted in Nairobi Stock Exchange in Kenya? I don't know. Is it that hospitals are not very keen to be open to the public, how much money they raise? Is that the mystery with the medical practice also which inhibits us from working as a group? I don't have the answer for that. The other comment I can make is that doctors are not entrepreneurs. We are scared of taking risk. It's a part of the training we go through. We tend to follow the mentors who led us the way. They were trained in civil careers, how to be employed and work at the same time, with no courage or guts to move out and be on your own. Thank you.
Right. Before I introduce the next speaker, maybe you can take a comment from the audience. Anybody with a comment? Yes, Dr. Oweru.
Where's the speaker? The mobile speaker.
Hello, thank you. Thank you, Willis, for that stimulating talk. I think I agree, solo practice should be dying soon. I think if you look at the residents who have qualified, Amadi in Baringo, Omito in Bomet, ask them how much urology they have done. It's almost zero. So what is the way forward? I think they should become entrepreneurs, form up a group practice and sell your expertise to the county government. Because, you're there, you have no instruments. The county government wants to buy ambulance and paint the hospital. I think we need to start thinking, how do we survive in this era of devolution? Must we be employed, or should we come up and form group practices that then sell their expertise to the county, just like everybody else?
Thank you, SNK. Professor Mungai, I'll give you a chance. Before I give you a chance, I'll also make a comment just based on what SNK has just mentioned. In our new COWS strategic plan, there is a big chapter on the welfare of the members. And part of this is thinly veiled, what we are talking about is thinly veiled in that plan. My question would be to the general membership, because it is easy to say that you guys go and set up a practice. What would be the role of the association in assisting members to come up with formidable practice, group practice, that will enable our members in far-flung areas to really engage in structured group practice? This is an open question and can be answered by anyone. Thank you.
Thank you very much, Francis. Now, this has opened something new that doctors have been uncomfortable to think. In any society, you are paid for goods and services that you give. You sell oranges, you're given money. You sell a service in a hotel, you're given money. It has been assumed for a long time that medical service must be given by the government. And indeed, this would have been so. And we know the NHS in the UK has been able to do that, albeit with difficulties. A country like Kenya is now headed to where the majority of services delivered is through the private sector, either by patient going to buy something from the pharmacy or going to see the local clinician or even coming to you. It is not going to be possible for people to raise money, start small group practices, and set up practices that would be of the standard that you find in India, where you can find a urology practice that can do everything, you can have a general practice that can do everything, and you can have a hospital practice that can do everything. What we are having in Kenya, and it's a danger to us, Dr. Matu, is that we are going to allow merchants to come and start this, and we will be employed by them. What is the role of the general membership of CAUS, Francis? I think the one thing we could do is give a prototype urology practice. If you produce a prototype urology practice, you can go with it to the bank. And because the bank knows what you're going to do, they'll give you the money. The best example of this is the Equity Afia clinics. That's how they've started, and they appear to be geared to going around the country. My fear of Willis being next to me, doing better than me, doing worse than me, should be thrown out of the window, and we have a practice, and we share the resources. And when you're in a group practice, believe you me, I'm going to say it in the open, you can hide your income. Thank you.
Thank you very much, Professor Mungai. We still have a few minutes. You can just a few comments because the keynote speaker is not coming, and the C will come around one. So before the chairman maybe gives his speech, maybe anybody the comments, you can still go ahead.
Okay, at the back. Yes, sorry, I might not know your name. Is the gentleman at the back?
Dr. Awad.
Dr. Awad.
Thank you. I have a question and a comment, actually. So my question, first of all, I feel like I've been the only COSEXA resident and fellow who's been coming to these sessions for the past few years. So my question is, considering that I know that some members here are actually fellows of COSEXA, yet for the entire 5 years I've been studying, I've not seen any COSEXA urology program being talked about. Maybe I can have a comment on that, because we have board recognition and international recognition. So maybe we can have a way forward of how we can partner on that matter. On the endotrainer part, I would also like to invite all students that we also have endotrainers in MATA. We have sessions every Tuesday at 7 a.m. And anybody else who maybe that time is not possible, we can actually organize with them. Thank you.
Thank you very much. I think we okay, Dr. Waweru.
Good afternoon, members.
Afternoon.
Okay, I want to talk as a partner, maybe because you need nurses also to help you do your work, because we are talking of group practice. You find maybe you don't want to practice with other people. You find a doctor preparing in his clinic, he's seeing patients. He doesn't have time, the patients are full. He wants to finish is when he wants to clear or to clean his instruments to do a procedure like TrueCut, prostate biopsy. He wants to do catheterization. He doesn't have a nurse. Why don't you also involve the nurses in your practice so that that money you are getting you're also able to share with them, because actually you need them in your practice.
Thank you very much.
Well received, Kamimo.
I think we are going to appoint somebody to answer that question. Dr. Misango, answer the question, and then Dr. Waweru can give his last comment.
Not COSEXA.
I will not, sorry, I will not answer the question. I'm sure somebody else will. My name is Dr. Misango. I'm going to make 2 comments. One of them will be addressing what the doctor has asked about COSEXA. Now, there's something, as the chair of the sessions were talking, Dr. Matu mentioned about why our practices and our hospitals are not included in the Nairobi Stock Exchange. And it was a challenge for us because traditionally, there I'm using the word traditionally again, we have always regarded healthcare as an non-profit venture. So we basically identify very much with this public perception that we should not appear like we are commercializing medicine. And I think that is something that came from the way our structures were established from independence, because as Professor Mungai has mentioned, it's always something which is considered a service being provided by our government. And as somebody goes into private practice, you're also expected to be following suit. But truth be told, it has to be something that is self-sustainable. It has to be something that is going to pay the salaries of the people around there. And it has to be profitable to the people who are running that as a business. So that is how things are going. Now, the challenge which we have as professionals in terms of increasing or rather improving our healthcare service provision is replacing what the ministry or what the government should be doing, because as somebody rightly put it, business people are going to take over. And business people, their intention is making a profit and employing us. I think at CAUS, if I'm not wrong, we're actually looking at a strategic plan where we are going to have a prototype hospital which is going to be run by ourselves, because we have what we think is required of the profession in Kenya to be able to set something which is going to be a standard so that people can benchmark with that. I can talk with authority also that there are some people, very young doctors who are in the Kenya Medical Practitioner Dentists Union, who are actually having this as a possible vision. Instead of people going to invest in buildings and building, as businesses, then people are setting up hospitals which can be benchmarked. And I think it's good that we're having this discussion now, because that is how we are going to go. Now, in regard to COSEXA, I happen to be a program director for COSEXA, and I know the challenges of any new professional organization or venture in a traditional setup, because people have very fixed minds. And I know it has been a challenge even talking about COSEXA in our CAUS group, because we feel threatened by anything which we do not know, which appears to be challenging our traditional way of doing things. And that has been the biggest challenge to the progress of COSEXA. However, more and more people are getting converted into understanding that as long as you are providing a service or providing something that is adding value to society, then people continuously keep on being added into that group. I had a very challenging task of trying to set up a COSEXA urology training in Kenya. I put out feelers to my colleagues in the COSEXA. The opposition,
Dr. Misango,
the challenges
summarize.
were there. Okay? Sorry, okay, I'm finishing. So just to add, just to finish, it's something which is ongoing. we will not make a decision and effect it immediately, but it's a work in progress. Thank you.
Okay, thank you very much.
Thank you very much. Just for Misango, that has been overtaken. COUS has a committee on education, which is working on harmonizing training programs.
Right. We have to move on to the next speaker. Sorry, Dr. Oweru, we'll give you a chance at the end if we have time. So our next speaker is none other than our chairman, the chairman of the Kenya Association of Urological Surgeons, Dr. Patrick Mburugu, who is known to us. He's a consultant urologist based at the Kenyatta National Hospital. Dr. Mburugu.
Thank you, Francis, for your introduction. I don't have a speech as such, just a few remarks for those who probably may not know COUS very well. So welcome to our 2021 annual scientific conference, and we are really grateful that you found time from your busy schedules, and not only time from your busy schedules, but time from your busy schedules in these dangerous times when congregation, traveling, etc., is looked at suspiciously. So thank you for coming, and I'd also like to thank those who attended the pre-conference surgical camp for a sterling job well done. Thank you very much. So those who do not know COUS, COUS was formed 25 years ago, and like Professor Mungai said, this is our 25th birthday, by 6 urologists. And it was formed as an umbrella body of the existing urologists then, for them to share experiences and look at their welfare and the future. It was registered in 2002 as an association by the Registrar of Societies. And from that small, humble background, where they used to hold meetings in either each other's offices or later on at Pan-Africa Hotel, it has ballooned into a 66-member organization with 45 full members and 21 associate members currently. Now, some years ago, I'm not very sure exactly how many, but some years ago, COUS came up with a COUS Week, which is a week where we used to have a surgical workshop, which was traditionally held in Kenyatta National Hospital, followed by what was then a half-day conference on a Friday afternoon, or on a Friday morning at Pan-Africa Hotel. With devolution, the COUS Week was also devolved, so that 4 years ago, we decided to go out to the counties, and rather than hold a workshop for the benefit of members, because the workshops were training workshops for the benefit of members, we went into service provision camps, where we provided free service to unfortunate members of society who could not afford to come to Nairobi for those services, which are rather specialized and cost intensive. So 4 years ago, we devolved the annual COUS Week, and went to Malindi, followed by Kisumu, followed by Meru, and this time we're in Kitui. Now last year, at the end of last year, Dr. Joshua Matu, who is an adopted son of Kitui, suggested, why don't we go to Kitui? And some people were like, Kitui, what is in Kitui? And I'm glad to announce that after months of arduous preparation by both COUS, the county government of Kitui, and members, as well as our partners, Kenyatta National Hospital, University of Nairobi, East African Kidney Institute led by Professor Mungai, as well as very many hours of input by the organizing committee, our secretariat, our pharmaceutical industry partners, and our equipment suppliers, we managed to deliver a sterling camp, as well as this conference, which started as a joke by Dr. Matu. Now, we were hoping that the county government of Kitui would be here, because I wanted to campaign a bit for COUS, but unfortunately they're not here. Anyway, long or short of it is that at the end of the camp, we managed to operate on 185 patients.
And of those 185 patients, we managed to perform 220 procedures. So 220 procedures on 185 patients. Now we cannot downplay the role played by the trainees and the nurses in this camp. We have had our trainees who did most of the work. They saw the patients before surgery. They did most of the surgeries and did the post-operative ward rounds. And I'm glad to say that we had no unforeseen or untoward incidents following the surgeries. Now, the future of cows lies in the young people, the trainees, the awards, and the Muigais and all of them guys who are in training right now, either in COSEXA or in the University of Nairobi. I don't know, this is probably the time to probably try and say something about COSEXA since, do I have minutes? No. No, I don't have minutes. I don't know if this is the time to say anything about COSEXA. I've been overruled. But cows in its future foresees several things happening, chief of which is a formation of a cow center of excellence, which will kill two birds in one stone. It will kill the Professor Mungai bird of setting up a prototype center, which will serve as an example for other centers of excellence in the country. While we were in Kitui, we noticed that there is a dire need for modern endourological services. And probably this is the right time to say that if anything comes out of this meeting, it should be that between us cows and the county government of Kitui, we should come up with a way forward in provision of modern urological services here. I don't know if I'm being insolent by asking the trainees who are native born of the larger Kamba nation to put up their hands. Trainees who are native born of the county government, of the larger Kitui nation. Karimi, I thought you were a Kitui person.
Yes.
Okay. Karimi, what about the gentleman?
Karo Ndio.
And the gentleman? Yes, Karo Ndio. And the gentleman?
This side.
Okay. I'm informed that we have the CEC of Health and Kitui. So, Madam CEC, you see you have homegrown talent. You have homegrown talent that will soon be exiting their training. We have various cadres of expertise here, led by Professor Mungai, all the way to the nurses. You heard about Eunice Kamimo talking about the nurses not being left behind. So if you want to set up endourological services here, we are more than willing to help. We can't spare time. You have manpower trained for free for you. And you have the equipment manufacturers on the other end at the exhibition hall. So we are willing to talk if you need us in that aspect. I would like to welcome Dr. Winnie Kiteti, who is the county executive for health, to this opening ceremony of Kenya Association of Urological Surgeons. Welcome, and feel free, feel at home with us. I think just before you walked in, I just announced that we operated on 185 patients, on which we did 220 procedures. And I'm glad to announce that all the patients are well. In fact, some are already at home. And we hope that in future, if you need us, we are more than willing to come. And we have your adopted son here, Joshua Matu, who, the adopted son of Kitui, who is our liaison between cows and the people of Kitui. If you ever need us again, just talk to him. We are more than willing to come. Thank you very much. Welcome to Kitui, everybody.
Thank you, Chair. Maybe the question in many minds there is, where is the next cow's week? That is not to be answered now. We shall give you an answer in due course.
The next speaker is Professor Peter Mungai. Let's give credit where credit is due. Professor Mungai is the director for IACI. IACI is the main sponsor for these COWS weekly sessions. Without IACI, we can't be here. Let me be very honest. For two things. One, they have been supportive and encouraging us all through. Even though they have no funds, they have always promised that they will make it possible for the association to proceed with the activities. And they have kept their word up to today. As you all know, that Professor Mungai has trained essentially almost all of us here in one way or the other. It's my appeal that also you young guys, you hold the mantle and train as many persons and supervise as many residents as Professor Mungai has done. When you do that, you'll have made Kenya proud. He's going to talk about the East African Kidney Institute, the status, the progress, where he is, what is he planning for, and as it is as of now. Professor, welcome. Thank you.
Thank you very much.
You see the attire is in. He's a man in action. He's not a urologist anymore, he's a plumber. Thank you, Prof.
Absolutely. I'll try and take 10 minutes, even less, and to thank everyone. I was telling some people the other day that on those days when we used to meet as 3 or 4 people thinking of the cows, we never imagined that we would see a crowd akin to what I'm looking at. I think this is the best legacy that we shall have for our country, Kenya. I think as urologists and the associations, associates like the nurses and the trainees, this is the best thing that can happen in Kenya, that an initiative of professionals has taken now to go and deal with people of Kenya and serve them without having to be served themselves. Those who give selflessly shall be blessed abundantly. And you are all blessed. Thank you very much, Patrick, for leading the organization in the manner that you have. So the East Africa Kidney Institute is an offshoot of COWS. In the early days, we had said, like you're saying, that we'll have a center of excellence. And when the sectoral meeting of East Africa partner states ministers met in Arusha, Tanzania, they thought that the best thing they could do is provide centers of excellence in the East African region. The orthopedic colleagues of ours took the mantle, and there was going to be an orthopedic center of excellence in the Republic of Kenya. But I think, Patrick, correct me if I'm wrong, the orthopedic surgeons do not hold free camps in the country, because the need for them to hold free camps is not there. Many hospitals in Kenya can be able to offer some level of orthopedic service. So the then Director of Medical Services said, what we need in this country is urology and nephrology services. That's what our patients suffer from most. And indeed, on Monday, we saw a patient who had stayed with a catheter for 12 years. It is unlikely that you're going to have waited for an orthopedic operation for 12 years. So that is what informed the formation of the East Africa Kidney Institute. It was hinging very much on the transplant program, because that is what was worrying the Ministry of Health in terms of services, up to and including the head of state, that people who needed urological services didn't get them. And from everywhere we have gone, we have seen this need, and that is why immediately thereafter we thought of a training program. And we started with the urology training program. It was the first to go off the tracks, and of course the urology program is the effect of which we are seeing today. Madam CNC, we think that we are serving Kenya. Having had 185 operations done in your various hospitals and 220 procedures, that surpasses any institution's number of patients done in Kenya in urology in a whole year. So this is a big service for the nation of Kenya, irrespective of whether it is in the public sector or the private sector. So that's what you can see on the slide, is that the East Africa Development Bank came and offered this center, which was to offer training, research, and service for the region. The IACI, University, KNH, KMTC building was supposed to be a needers for such other institutions to spring up in the rest of the country. So the vision was that it should be an internationally recognized center committed to scholarly and professional excellence in both urology and nephrology. May I say here that with this institute, we looked at providing all the necessary things in training of urology and nephrology. And urology and nephrology appeared to have other allied professionals, including nutritionists, including vascular surgeons, including pharmacists and nurses. All these are part of the vision we had for IACI, and this has since taken over. As we were presenting the other day in the evaluation of the work that is supervised by, or is funded by the Africa Development Bank, this is one of the projects that has performed very well. Of course, to get to that vision, we had to provide quality medical education and training through creation, preservation, integration, and utilization of health and knowledge. That was our mission to that vision. The building that we are talking about is that 4-story building, which I thought was a dream in the year 2008 when I told the Department of Surgery that I had a dream that we would have a regional center that would train urologists and nephrologists, and my item was removed from that agenda on that morning. I have no apology saying that this was done in 2008 in spite of my having circulated the project as I saw it in 2008. But the project as seen by the nation of Kenya in 2014 is what you're looking at. And yes, through that mission, we are going in that direction. Sometimes in August last year, excavation was done and we had the pillars laid down. And that is what followed. Tumors and tumors everywhere. And now, that is in the far away from that helipad of KNH, you can see the institute as it comes up. So, the institute that we have is providing training. It is having a building, but it's also providing training. We have a master's in urology. It's the best we have, 21 trainees. Master of Sciences in renal nursing, 12 trainees. Fellowship in clinical nephrology, 11 trainees. Fellowship in pediatric nephrology, which was never looked at, 5 trainees. And diploma in renal nursing, these are current students. We have 82 students. And so, even for SAWA, the programs, the pediatric programs, that's why we started the pediatric nephrology program. We believe that we have the people who can provide the pediatric urology training as well, as distinct from pediatric general surgery. And I hope that that will be the next thing that we'll be discussing, that the Institute will be having so many. In the next 1 week, we are introducing the PhDs for the Institute. So if anybody wants to apply for PhDs, we have PhDs for the Institute for urology, nephrology, nursing, pharmacy, nutrition, etc. So in 2014, when the Institute was first formed, the government heard of it. What did they do? They asked us to train for the whole country in the rollout of renal dialysis in all the counties. Madam CEC, I'm sure you agree that your country was supported to train for renal dialysis, including training. This training included nurses, physicians, medical officers, nutritionists, and all. And we've done that. I'm proud to report to this audience, because IACI is a child of CAUS, that we've done so for all the 47 counties in this republic. So you see the population that we have talked about, student enrolled is 328. So the complex is in progress. We have trained 130 students, various courses 328. We have also taught people through webinars, through the medical equipment scheme. We've provided this, and then we have formed linkages, and we are always forming linkages. Just last week, the University of Manchester came on board. The University of Sheffield is on board. The Apollo hospitals from India are on board. The Peking University from China is on board. And we also have the IDZOMO group, which is both South Africa and Australia. And we are expanding. We have just had, as I was seated in this meeting, about 5 inquiries of people who want to collaborate with the East Africa Kidney Institute. It is a national institute, but it is also a regional institute. It is a regional institute in terms of doing all this. So what does it look like? It has to do ward rounds. All the training activities as listed up there. I don't need to go into them. Then there's the question of research. One of the ones that we had was the epidemiology and outcome of kidney disease at the Kenyatta National Hospital, which we expect to be rolled out to the rest of the country. We have the money and the mandate to do a registry of all the renal issues in the East African region. And that's one of the things for which we have hired a consultant so that he can lead. And I ask all of you here who deal with that to participate. So those are the kind of things we do. You see the AFRAN meeting, and I didn't mention at the beginning, I lost a close friend, somebody who was instrumental in what IACI was doing. And for those who know Dr. Anthony Were, his gap has been impossible to fill. We feel his absence every day. Many people in this republic know Dr. Were, who unfortunately succumbed to COVID. So we have virtual for various presentations on like we had one on organ donation. We have had contrast-induced nephropathy, hemoperfusion. You can see Dr. Were there was one of the leaders into it. We have external rotations. We even go up to Apollo in India. And yes, we can see the group of nurses who were there. It's myself with people from Peking University. And so my feeling is, if everybody embraces what we have, every county should stand to benefit. And the reason I stand here with the engineers dressing is to show that you don't have to be an engineer to make a complex. Make a complex in your head, and you can translate that into an institute on the ground. The people to do it are there. For those who want those courses, they are all available on the University of Nairobi online. And if you come to the institute, we shall be able to help you. And lastly, like I said in my first presentation, it's a happy birthday to CAUS, and it has produced an institute on its 5th birthday. Thank you.
Thank you very much, Professor Mugai, for that insight speech and wise advice to the prospective students who wish to join the program. We are honored to have the presence of the CC Health, Dr. Winnie Kiteto, amongst us as the chief guest, who is hosting us for the last 3 days and are going to be with us for the next 2 more days. With us is the Dr. Wino, the Director for Medical Services. It's Dr. Wino who has made this program a success. He's really worked day and night to make his team coordinate all the activities so that you got the patients on time and in place. We are very grateful about your efforts, Dr. Wino. On behalf of CAUS, thank you very much. For the persons who don't know Kitui very well, Kitui is 170 kilometers from Nairobi through Thika Road, 140 kilometers from Nairobi through Machakos Road, with a population of 1.1 million. 600 of them being men and around 500 being women, covering an area of about 40,000 square kilometers. Of that population, there are about 352 health facilities of various categories. I think there's only one level 5 hospital, although it's graded as a level 4 hospital by the Ministry of Health, and I think about 4 or 5 other level 4 hospitals. What you are lacking in the county is not human resource. The human resource is there. The county government has trained quite a number of special doctors. There's even a student they are sponsored for urology, so you'll soon be a member of us. He's training somewhere else, not in the country. Of concern is the facilities for minimal invasive surgery, the surgery we are doing today, the so-called endoscopic surgery. For that population of 1.1 million, the only facility which can be able to train or offer minimally invasive surgical procedures is only one, that's Jordan Hospital. I believe the county is endowed and rich enough to make such a facility within their county facilities. If there are difficulties training your staff, COWS can be able to facilitate where to acquire equipment and the training for the same persons. We believe in transfer of skills. We don't want to be coming to solve Kitui's problems. We want Kitui to be able to solve its problems. That's why we spend a week around here. I take this opportunity to invite Dr. Wino to make a few words. Then he will invite the CC Health, Dr. Winnie Kitetu, a consultant psychologist, to talk to us. Thank you very much. Wino, just say a few words. Be brief.
Good afternoon, everyone. I take this opportunity to welcome all of you to your scientific conference. We are grateful that you chose Kitui as the venue for having this conference. And I think for the last 3 days, you've been able to offer special services which residents of this county were very much in need. So without further ado, I'll just take this opportunity to welcome the CEC for Health and Sanitation Kitui County, Dr. Winnie Kitetu. Karibu Waziri.
Good afternoon, everyone. Good afternoon. Through the chair, LOC, and COWS Treasurer, Dr. Matu, all the doctors who came to our great county of Kitui. I can see Professor Gugi Mungai, because I'm not new to him, and others probably I don't know by him. I'm hereby pleased to be before you this very special, important occasion. My name's Dr. Winnie Kitetu, as you've heard, and for sure I've interacted with most of you doctors in Kenyatta National Hospital. You're not new to me. I also interacted at Aga Khan University Hospital. Being a pharmacist by profession, then I diverted to pursue my passion in mental health, up to PhD in clinical psychology. Then I found myself CC Health and Sanitation in Kitui County. I want to give apology for Her Excellency, the Governor, who due to the unforeseen circumstances, she could not be here today. However, I came to represent her, and I'm going to read her speech. Ladies and gentlemen, it gives me a great honor to be with you here on this auspicious occasion of opening this scientific conference of the Kenya Association of Urological Surgeons. We are grateful that you chose Kitui County as a venue for your meeting. In this county, we pride ourselves in welcoming visitors. This is one of the richness we have as Kamba community. Healthcare is one of the 5 pillars of my manifesto. Healthcare is central to well-being of any society, and that is why in Kitui County, we strive to give the best healthcare we can. With a population of 1.3 million and an area of 30,000 square kilometers, we stand to be the largest in the Lower Eastern than Makueni and Machakos. It is crucial that we give health services to every corner of this county. In human resource for health, we have recruited 645 healthcare workers, which represents a 54% increase in the workforce, leading to better delivery of services across the county. The number of operational healthcare facilities now stands at 293, up from 230 when the governor took over our office 3 years ago. This is leading to more accessible access to health services for the rest of this county. Specialized equipment have been installed in our all level 4 hospitals, including state-of-the-art CT scan machine at the Kitui County Referral Hospital. We have a digital X-ray machine at all other hospitals. We also have a renal ward where we have 7 beds, dialysis beds, 2 in Mwingi Level 4 Hospital, and 5 at Kitui County Referral Hospital. And when I visited a CEC for Health, when I visited the hospital, nurse was telling me that that capacity, she has more patients than the beds. So that is one of the needs which we may have to expand our renal unit, because the last minute time when she takes patients, it's around 4 o'clock. And when they have to run for 4 hours, then you find they close very late. Knowing that provision of healthcare can be expensive, we launched the Kitui County Health Insurance Scheme. Through this scheme, Kitui residents are enrolled at a cost of 1,000 shillings and receive health services in all public facilities in the county. We welcome all partners to assist us in achieving our mandate of giving health care to residents of this county. That is why we are happy that you chose Kitui County, not only as a venue for your scientific conference, but also offered much needed specialized services to the residents of this county in the last 3 days. We are happy to learn that you've already operated on 185 and then done procedures on 220. That is great. As Professor has said, maybe it has never been done in another county. Kitui, it did. We are grateful. And that also goes along with, I did a lot of Kikamba announcements on Monday. It went viral so that people can come and seek this specialized treatment. For that, we are so much grateful. The shortage of the health specialists in Kenya means that we have to partner with organizations such as yours to offer much needed services to the people of this county. The county government of Kitui has embarked on the production of non-pharmaceuticals, which is being done at the Kitui Pharma Industries located at the Kitui County Referral Hospital. Products from Kitui Pharma, such as sanitizers, will not only enable the county to save money on those products were being purchased from elsewhere, but also bring in much needed revenue for the sales to other counties. It is worth noting that the products from the Kitui Pharma have been certified by the Kenya Bureau of Standards. This is alongside other industrialized projects which we have, that the famous Kikotech textile, which is ongoing, and which maybe at the end of it, I would encourage you to go and just do a suit or a shirt while you are standing, and you get the best shirt from Kitui County. As you discuss on how best to manage patients in your area of specialization, please also take time to visit the first beautiful county of Kitui. In Kitui, as I've told you, we have that textile industry, Kikotech. There are many tourist attractions, including the Nzabani Rock, for those people who are fed up with their gender. You go around the rock 7 times and you become the other gender. So that is one of the pride of our Kitui. And then alongside that, we also have Safo National Park up towards Mutomo, where you'll be able to see the elephants and many others. So with those few remarks, it is my pleasure to officially open this edition of Scientific Conference as the Kenya Association of Urological Surgeons. I want to declare it officially open. Thank you.
Thank you very much, Madam Cici. We're very grateful for that nice speech. And we're very grateful that you are with us. We had said that we'll give you a stand at the exhibition center so that Kitui can also exhibit the products we are talking of. I'm not sure whether you took that offer or not. If you never did, we are still here today and tomorrow. You can still have the stand there. There's an exhibition there. Then you can exhibit the nice products from Kitui. And then if there should be some merchants for sale, if you want. These are surgeons, they need scrubs, and they said you make very nice scrubs. You should take advantage when you are here. We're also inviting you that after lunch, because we're going to take lunch with you, you also tour the exhibition there. There are nice medical equipments. You can share contact with the agents, the distributors, and then they can be able to support you if need arises. Before we break for lunch, I'm requesting to be just calm a bit, want to give some presents or gifts to the participants who made the camp success, so that when you come after lunch for the next session, you can be able to release the county team. Catherine, please, let's move.
So thank you very much. The first gift we have to offer, maybe CEC, so that we can capture we know your face properly. You can remove Barakoa for a second. Yes. I'm highly suspicious. I don't know whether we were classmates. I'm not sure. Yeah? Thank you. So the first gift is to the county government of Kitui, and I would like to request the chairman of the Kenya Association of Urological Surgeons to hand over to the county government of Kitui. The next one is to the Jordan Hospital, Kitui. The Jordan Hospital, Kitui. I would like to request the Chief Executive Officer of Jordan Hospital, Kitui, to come and receive his gift. Mutomo Mission Hospital, who have been very supportive. A representative from Mutomo Mission Hospital. In the absence of somebody, I'd like to call upon the House Vice Treasurer, Dr. Waweru, to receive on behalf of Mutomo Hospital. Dr. Waweru has done a lot of work with the Mutomo Hospital. The next we call upon the next hospital we want to gift is the Kenyatta National Hospital. In the absence of the director of the Kenyatta National Hospital, I would like to call upon Dr. Willie Otele, who is a chief medical specialist at Kenyatta National Hospital, to receive it on behalf of the CEO. Next, we want a representative from Mwingi Level 4. It was called Level 4, eh? Mwingi Hospital, a representative from Mwingi Hospital, who have been very supportive in this camp. Dr. Mohammed and your team. In the absence of a representative, okay, thank you, Dr. Wino. So Dr. Wino is receiving on behalf of Mwingi Hospital. And before Dr. Wino goes to sit down, I'd also request you to receive on behalf of the Kitui County and Referral Hospital. Thank you very much for partnering with COUS in making this activity a tremendous success. After Moi Teaching and Referral Hospital and Malindi Hospital, Kitui County Public Hospitals have been very supportive. Next, I would like to call on the director of the East African Kidney Institute, who is dressed like a Seremala today, the director of the East African Kidney Institute has been very, very supportive of CAUS activities. And you can see we have promoted the professor, is now a full Seremala. Thank you. So thank you very much. That's it for this session.
Thank you, James. Thank you very much. And just any housekeeping, Catherine? Any housekeeping issues, James?
Okay, thank you very much. Now we want to break for lunch. All delegates are going to be given a lunch voucher, and lunch will be served just up there, just a few meters away. And we would also like to request all delegates, please find time to visit the stands. We have pharma industry displaying their products, and would really appreciate if you find time to visit the stands. I think it is now 1:20. We start at 2 o'clock?
Yes, 2 o'clock.
Yeah, so it's now 1:20. We can break for lunch, so we'll start at 2 o'clock. Thank you very much for your attention.
Francisca. When we are deciding the gift.